concerned because all these, if any biomedical waste, if it is contain any infectious material like any bacteria, fungus, or any virus, like any pathogen that can cause disease to any healthy person, or it can be toxic to environment. That's why we have to concern about this biomedical waste. And when we come to the hospital waste, these are mainly two types, hazard and non-hazard. Hazard, it is around 15 to 20%, it is hazard, and non-hazard, it is 85 to 80%. Hazard waste mainly non-infectious and infectious. Non-infectious এর মধ্যে যেগুলো আছে সেগুলো হচ্ছে chemical and others. Chemical waste, it can be generated from housekeeping, hospital cleaning purpose, all those things. From this portion, the chemical waste can be generated. And infectious waste mainly from any patient body fluid, or any body fluid, or any infectious material that is also, that may be sharp. Previously in first class I have told about needle stick injury, blood and solid, that is blood bag, like that, without needle, syringe, those are solid waste. And what I told, that infectious, what does it contains? Infectious agent, toxic, hazard agent, SARS, genotoxic agent, radioactive agent. Genotoxic means it is toxic to DNA or genetic material. That's why it is genotoxic. And some general waste also can be generated, like patient food and all. Those are only general waste. And pathological waste consists tissue, organ, like from the pathological laboratories, or any OT, operation theater also, that pathological waste can be generated. Infectious waste, that is also from can be generated from hospital and wards. By the same time, microbiological laboratory or any other laboratory, pathological laboratory. SARPs, that is also mainly any needle or broken glass, scalpel blade, these are come under SARP. And pharmaceutical waste means any expired medicine and all, that will come under pharmaceutical waste. Or any spill, means you are carrying any medicine bottle and that fall from your hand and it has broken on the ground. How to manage it? That is called spillage management. I will come to that spillage management later. Then chemical waste means any discarded solid like bleaching powder and all we are using to disinfect the environment, and some Lysol and all to clean the floor. Those will come under chemical waste. Radioactive waste, some radioisotopes, X-ray, all those things, that will come under radioactive waste. And sources, what I told, any hospital, physician office, dental office, dispensaries, blood bank, animal house laboratories, or any research laboratories. From here we can, means these waste can be generated. And first of all, when waste has been generated, we have to keep in mind, we have to manage it. How to manage it? Some regulations are there. In 1998, the first regulation has made, and they have made some categories, around 10 categories they have made. They made the categories like the infectious or corrosive, or it is a chemical hazard, like that. They have made the 10 categories. And after that, 2016, again the new amendment has came. They have mentioned some color code, where the sharp will discard, where any infectious body parts will discard, where the plastic glasswares have to discard, like that. After that, 2018 they have made again the new amendment, and that amendment also made some color code, or and they told that time that chlorinated plastic have to use. After that 2019 again second amendment has came, and that second amendment has told that color code, all those things color code I will go one by one. And those color code, when you are discarding any sharp, any body fluid or any infectious non plastic, there you have to put it in the yellow bin, or and on the bin direct means clearly you have to mention that it is biohazard. Next will come red color. In the red color you have to put all the non degradable or plastic materials, like syringe, gloves and all. Then will come white container. White container should be puncture proof, and there you have to put all the sharps like scalpel blade, needle, all those things. Needle with fixed syringe also it will come under white container, and white container will contain 1 to 2% hypochlorite solution. And you have to keep it in mind that 2/3 you have to fill. After that you have to seal, and you have to store it in the common waste storage area. হ্যালো, কিছু অসুবিধা হচ্ছে? অনেকক্ষণ থেকে কি হচ্ছে ডিস্টার্বটা? Then blue color will come. In the blue color, glass materials or any recyclable material we have to keep, like any glass slides, glass container, any ampules we have to empty ampules we have to put it in the glass container. And glass container, it can be a cardboard or anything, or it should be yellow marking. And any other waste like biodegradable waste or non-infectious waste, like any food material or anything, that you have to store or you have to put it in the green bag. Genotoxic waste also can be, you have to store in the yellow bag. Okay, and that can be mutagenic, means it directly affect on the DNA or RNA. It makes some mutation on DNA and RNA. Teratogenic means that has some impact on embryo growth related deformities will be there. And carcinogenic means it can cause cancer. When at first we have to keep it in our mind that we'll try to make sure that generation means in any work, if we are generating any waste, we have to keep it in our mind that waste if it is not necessary, we will not create any waste. Okay, and after if the waste has generated, at first step it is you have to categorize. Categorize means if it is infectious or non-infectious, if it is biodegradable or any plastic material, if it is sharp, like that you have to categorize. And as per the categorization you have to put it in different bins, different color coated bins. Then you have to store it in a common storage area, and you can store in your facility like hospital or any lab. Within 48 hours you have to dispatch it. And where to dispatch? You have to dispatch it in common treatment facility or any agency. They will treat it, and as per their treatment. If it is like any bacteriological laboratory, from bacteriological laboratory, if any waste is generated, you have to at first you have to treatment in your facility, like from the bacteriological lab, any culture or anything, that you have to put it in a autoclave, and you have to make it sterilization. Then you have to store it in the common storage area. Autoclave means it will sterilize the material. How? It is an instrument in the lab, it is present, and here you have to buy moist heat sterilization. The mainly autoclave principle is moist heat sterilization, like 121 degree centigrade for 15 minutes, 15 psi per square inch. You have to maintain it, and in this process even the spore, bacterial spore, will also die, and after that you have to store it in a common storage. After that, within 48 hours you have to send it for any common treatment facility or agency who will take care of it. And from where the waste has been generated, outpatient, here the solid waste means any cotton with blood, or soiled, or any pop cast, all those things will outpatient area you can find it. Injection room, there solid waste, soiled waste, solid waste, sharp, you can get it. General ward, there also sharp waste, soiled waste, and solid waste also you can find it. Labor room, body parts, placenta, etc., you can get it. Operation theatre, body parts, sharp waste, solid waste, and soiled waste also it can be generated. Like laboratory, pharmacy, in the pharmacy, discarded medicine or any expired medicine also you can find it. After that, at first you have to segregate, means when the point of generation waste is generated, at first you have to segregate in different color bin, different color coded bin. Here you can find that different color coded bins are there, means blue, yellow, red, and white. Means when a waste has been generated, as per their color code you have to separate it. Okay, means if it is sharp, you have to put it in the white puncture proof container. If it is infectious, body fluids, or any infectious material is there, or any cytotoxic or pharmaceutical waste, that you have to put it in the yellow bin. After if it is glasswares or any gloves, face shield, all those things, it will come under red bin. And if it is glasswares, then you have to put it in the blue bin. And when you are carrying, after storage, you have to carry for the common storage area. The route will be predefined, means predefined route you have to carry it. People should know that waste will carry in this, through this route, like that. And if it is and when you are carrying, you have to take care about that any accidental spillage or anything should not be happen, means your waste should not come out from your bins. After that, you have to store it in the common facility. You have to store it in the common storage area for 48 hours only you can store it. After that, within 48 hours, you have to send it for common treatment facility like CBMW TF, means that BMW treatment facility, central BMW or common BMW treatment facility will be there. Any agency or anything, like here we have one agency, they will come and they will collect all the biomedical waste. Sometimes you can find one car is there, that white color car, and that kind of biohazard sign is there on that car, right? That car will collect all those things and they will take it to their facility, and they will make it for further use if it is reused, or if it has to be incinerated, they will incinerate, like that they have to perform. And when you are carrying or you are handling, you have to take care about your PPE. You have to wear mask, cap, ground, any boot, gloves, different lab gloves. It's a different, but when you are carrying waste, the gloves, it is, you can find that is a different type of gloves they are using. And particular different bags, this kind of bag you have to use, means in the red color bin you have to put a red color bag, yellow color bin you have to put yellow color bag, like that you have to. And here you can find that it is a old picture actually, cytotoxic level is there, but now black or any green bin, after 19 amendment, second amendment, that green color, or you can use green or black color bag or container for any household waste. That particular, you can find that particular trolley is there. That trolley is dedicated for that purpose only, to carry the waste and all. Okay, and when you are mentioning that biohazard, you have to mention that particular stickers like biohazard and cytotoxic, and you have to label shall not be washable or permanently. It is prominently visible, should be prominently visible, or it should not washable, like that. That kind of symbol you have to use. And this yellow bag, in the yellow bag, any anatomical waste, solid waste, any chemical waste, pharmaceutical waste, you have to put it in that particular bins. And that bag you are using, that bag should be non-chlorinated bag, because in the high temperature that those things will go for incineration or autoclaving, like that. But in chlorinated bag, in high temperature, chlorine gas will come out, and that is hazard for health. That's why that new amendment has made that bag should not be any chlorine particle, or it is non-chlorinated yellow or red or blue bag. And the treatment is you have to incinerate, or sometimes if it is infectious, like any waste from biological laboratories or any biotechnology laboratory or any microbiology laboratory, at first you have to autoclave it in your facility, means in our hospital that has to be autoclaved. Then after it will store to the common storage area. From there, that biomedical treatment, any third party, or if you have any inside your hospital, if you had any different treatment facility, there you have to carry within 48 hours. And next it is red. There you can find that is infectious, but it is plastic or any non-degradable material like gloves, face shield, goggles, and some catheters, tubings, syringe, plastic syringe without needle, obviously without needle, syringe, those things you have to put it in the red bag. And that you have to, means the final treatment, it is autoclaving. And if it is required, you can for the treatment facility, they will make it for other purpose also, or you can generate from this kind of waste, you can generate any other energy, like that you can utilize this waste. White, in the white container, that will contain needle, syringe, and fixed needle. Obviously some fixed needle will be there in that syringe. If it is fixed, then you have to put it in the red white bag or white puncture proof container. And sometimes needle is there on that syringe, and you can make needle cutter also, or needle burner. After that, the needle will come to the white puncture proof container, and that syringe will go to the red bag. Okay. Then blue will come any metallic body implants. If any metallic body implants is there, that will come to the blue container, or any glasswares, broken or discarded any ampules or glasswares, that will come under blue container. And that can be recycled after any autoclave or any other treatment facility, that can be recycled. And obviously in the white container, you have to put 1 to 2% hypochlorite solution, and it is for 20 minutes. You have to keep it for 20 minutes, then only it will get disinfected or sterile. That different, if it is a cytotoxic drug or any drug, that yellow, you have to put it in the yellow bin, right? That yellow bin should be like this, a closed container like that. Yellow bin will be there, and in that bin you have to put all the cytotoxic or any genotoxic or cytotoxic drug or pharmaceutical waste. You have to put it like in particular kind of container. What I told that cardboard box you can use, and that cardboard box should be marked with or labeled with blue color tape. In the yellow category, that any animal or any animal body parts or human body parts you can discard, and even the some pharmaceutical waste also, and you have to store it in different. If it is an anatomical waste, you have to store it in a different yellow color. If it is cytotoxic or genotoxic, you have to store it in a different yellow color container. Then central storage facility, you have to store it for only for 48 hours. Always it is 48 hours you can store it for central storage facilities. Then BMW TF vehicle will come and they will collect all the waste, and they will put it in the common storage in their storage facility, and they will make it for further treatment. Yellow category also will come, that microbiological cultures or infectious material, that you have to at first in your lab only, or inside your hospital, it has some common treatment area. There you have to autoclave it, then you have to store it, then you have to send it in the central storage facility, then send it for the final treatment. Some liquid is also there, means housekeeping cleaning part is also there, some bleaching solution, hypochlorite solution, that also you have to make, means inside your hospital. Those you should not drain it in the common drain, or you can discard it like common water or anything like that, you can discard it. Only you should have some separate collection system. In that collection system you have to treat it properly. Then after treatment you have to check it, that you have to taste that particular effluent what you are treating, then you have to throw it in the common drain. Red category, in the red category, that you can find that some plastic materials or non-degradable materials are there. If it is like if it is NS bottle, then before throwing you have to mutilate it, means you have to cut it or you have to break it, then only you can throw it. After that in the container you have to keep it, and central storage area, then the treatment facility you have to send. There they can make it recycle, or before recycle they have to, at first they have to sterile or they have to autoclave it. White category, that needles and blades will come, and you have to preserve it in the white color container, or it should be puncture proof, and it should contain 1 to 2% hypochlorite solution. In that solution you have to keep it, and after that you have to store it in the central storage. Then you have to send it to the final treatment facility. There they will autoclave it, or they will heat dry, anything they can do it, and after that they have some different treatment facility. They can recycle it, they can like municipal landfill, they also can do it, and some encapsulation also is there by cement. Some sharp pit will be there. In that sharp pit, in your common facility also, in your hospital, you can make it a sharp pit, and there also you can put all this sharp with cement. Blue category, that any glass ampules or any metal that you have to discard, and that you can find that hypochlorite solution is also there. If it is infectious, then you have to put it in the hypochlorite solution. Then you have to disinfect it. After that disinfectant, you have to store it in the blue color. Then you have to store it in the central storage facility for 48 hours. You can only store, means within 48 hours that car will come to collect. Okay, and that central treatment facility, you have to send it. After that, they can again they can autoclave it. Again they can autoclave it, and after that, if it is recyclable, they will recycle, means glassware it can recycle, right? That's why they can send it for recycle also. Mainly that we miss, means when you are discarding all these things, you are putting yellow to red, red to yellow, or like that. That's why some I collect some material, that here you can find that nitrile gloves, it will come to the red, but we will throw it in the yellow bin. Okay, it should not throw it in the yellow bin, we have to throw it in the red. Okay, central venous catheter also it will go to the red. Okay, and in the red bag sometimes we throw blood bag in the red, but blood bag that it is contain plastic, right? Outside plastic, that's why we will wrongly will throw it in the red bag, but it will come to the yellow, because body parts are there inside, that blood is there, right? That's why you will throw it in the yellow bin. Okay, then white, in that white color, because sometimes we think that broken glass slides it is sharp, we have to throw it in the white box, but we should not throw it in the white box. Where we have to keep it in the blue color container, we have to throw it. Okay, sometimes in the blue box, cytotoxic drug bottle will throw, because it is a glass bottle, that's why we will throw in the, because in the blue color coat we will put glasswares, that's why broken glasswares, that's why we will put it in the blue color container, but it will come to the yellow color container. Okay, these things we have to keep it in our mind. And that common treatment facility, incinerator, that BMW or some agencies are there from the environment, Ministry of Environment and Forest. They have that facilities, like, or means they can sometimes autoclave will be there. In our facility, what kind of autoclave we can do, that any material from microbiological lab or any pathological lab, we can make it we can autoclave it, or from the blood bank, that blood bags, before throwing we have to autoclave it. But that treatment facility, they should have some autoclave, and incinerator they have, means greater than 1200 degrees centigrade they have to burn it. Okay, and do's that generate waste when it is essential. Without essential, we should not generate any waste. Okay, means inside our campus also you can find some food material or food particle, some plastics cover, here there we are throwing, means packet of ice cream and all, here there we are throwing. We should not throw like here and there, we have to put it in a particular bin. Okay, and if it is required, then only we will generate waste, otherwise we should not generate any waste. And segregate, means when you are generating the waste, if it is a plastic, you have to put it in the which bag? Red bag. Okay. If it is anatomical waste or any infectious body parts or any infectious material, biodegradable, that we have to put it in the yellow bin. Means in the point of generation you have to segregate fast. Then because when you are segregating, that particular color code should be there, and you have to put it in the particular color code. And when you are any NS bottle is there, when you are generating, means when you are throwing, before throwing you have to discard at first, means you have to break it at first, then you have to throw it in the particular bin. Which bin? Red color container. This before throwing needle, means we have to discard it in needle dispenser, there you have to, or needle burner, you have to, at first you have to burn or you have to cut the needle, then that plastic material syringe is there, that syringe you have to put it in the which bag? Red bag, and that needle it will come to the white puncture proof container. If it is domestic waste or any in the hospital also, that domestic waste can generate, there you have to put it in the green. That will depend in that hospital with green or black. You have to put it. Then when you are carrying, you have to keep it in mind that everything should be carried through a closed container and dedicated trolley. The dedicated route should be used, and don't like will not mix all the means hard glasswares, plastics, body parts, will not mix it. Okay, will not mix it because in the class of needle stick injury I told, the chances are there for needle stick injury or any cut injury, and impact of that is any disease like HCV, HBV, means hepatitis B or C, or HIV also can be spread. Never store beyond 48 hours, means in our facility we will not store beyond 48 hours, and will not overfill also. Okay, 2/3 we have to fill, and after that we have to close it, close the container, means white color container or any container you are using, you will not fill up to the mouth, only 2/3 you have to fill. After that you have to send it for the common storage area. Okay, and specifies when you are carrying that particular waste, the predetermined route should be there. In that route, before carrying that waste, you should have some particular time. That time, and that predetermined route should be not that much of crowd and all like that. You have to carry it. And role of, it's not the role only for doctors, all the healthcare persons or for a human being, you have to maintain all that biomedical waste, how to discard it, or any other waste also, household or any waste, you have to at first you have to segregate point of generation, what I told you in do's. Then you have to proper, means today what I told, that yellow, red, white, blue, this kind of color code, right? Before that, what was there? 10 different categories it has mentioned. When in 1998, that first amendment was there, that time 10 different categories was there. Now it is that only this 4 different color code is there. Household it is green, it will come around 5. Then next amendment it has also can change, right? Previously they have made that black color container should contain cytotoxic drug, cytotoxic any waste. If it is cytotoxic waste, then you have to store it in the black color. Now they have removed it. Before that also they have made that they didn't make any rules, specific rules for the plastic bags. Now they have made that rules for plastic bag, it should not be chlorinated, or it should be non-chlorinated, like that they have mentioned. That amendment can change like that, and you have to apply this amendment when that regulatory will change. And that final thing, it is conducting training and workshop for time intervals in your facility or hospital facility. You have to teach people knowledge sharing, brainstorming, like that, where to discard, and you have to survey that discard is growing properly or not. Like everything it is discarded properly, or point of generation they are discarding all those things, you have to make it survey, and according to that you have to conduct training session, brainstorming, or any knowledge sharing session like that. And last, that spillage management. Spillage management means if any spill, like any body fluids, or any infectious fluid, or any cytotoxic fluid will the, fall from your hand to the floor, that time some liquid uh, spillage will be there, and that you have to manage. That spillage is mainly two types: small and large spillage. Small spillage means it is less than equal to 10 ml. 10 ml, that is small spillage, and more than 10 ml, that is large spillage. And how to manage? If it is small spillage, management is different. If it is large spillage, the management is spillage management, it is different. In that small spillage, only on the spillage you have to put one blotting paper, and on that blotting paper you have to spray, or you have to put some disinfectant solution, like 1 or 2% hypochlorite solution, and you have to wait around 20 minutes, and there you have to display that spillage management. Means any spillage is there, that you have to display that standee, that some spillage is there. Okay. After that 20 minutes, you have to, means you have to wear or before going to the spillage management, you have to wear proper PPE, like gloves if it is required. Second gloves also you can use, primary gloves, and secondary gloves also you can use. Then face shield if it is required, face shield, mask, hair cap, apron you have to wear, boots you have to wear, then you have to go for the spillage management. Okay. And if it is large spillage, at first you have to surround all the spillage by a cotton, means you have to make some wall surrounding the spillage by cotton, or any spillage management. In the spillage management kit, some sponges are there, that also you have to make sure that spillage will not flow through the floor. After that, you have to put, means you have to cover, fully cover that blotting paper or any tissue paper on that spillage, and on that you have to spray some disinfectant solution, like 1 or 2% hypochlorite solution. Then you have to wait for 20 minutes, then you have to remove it, and again you have to, after putting all these blotting papers and all, you have to collect it, and again you have to spray that disinfectant solution, and with a clean tissue you have to clean it. Then you have to make sure that with disinfectant solution, or like Lysol, or Domex, like that you can find it in the market also. Those things you have to spray it, and you have to clean that area. And before starting that spillage management, you have to put some display, like standee, like spillage is there, that kind of precaution you have to take. And obviously you have to put that PPE, like that, donning and doffing, previous class I told, like that you have to put it, and you have to properly manage all this spillage. Okay. Or any question? Okay. Thank you.
Phase of the abdomen today. Next week we move to the head neck. The last part, the perineum. Already you are now familiar with the picture. This is the picture of the perineum looking from, as the patient is in lithotomy position. That's when edge of the table, the two legs are apart. And we viewing this, our lower part of the torso. So this is the whole picture of perineum. And for the sake of convenience, it is the midline. There is a fibromuscular, very strong body called perineal body. And we draw an imaginary line from the anterior end of the ischial tuberosity, interischial line. Divide this whole perineum into anterior urogenital triangle and a posterior anal triangle. And this posterior anal triangle, in the anus you draw an imaginary line here, vertically, each half is known as the ischioanal fossa. And it is the urogenital triangle. And if you dissect the urogenital, in female, there is another opening, it is the urethra and it is the vagina. It is, if you cut the fossa, then we find the fossa colis, then we find the perineal membrane, then the upper part, previous view, superior fossa of the urogenital, inferior fossa of superior fossa of the urogenital diaphragm. এখন আমরা বলছি না, ওখানে simple loose areolar tissue আছে, there is a loose areolar tissue, we call this endopelvic fossa. So it is this, if we cut in this section, coronal section, in a male, this is the anterior abdominal wall, this is the penis, this is the scrotum, this is the perineum, behind this is the perineum, and this is the posterior abdominal wall, right? And it is the skin. Beside there is a superficial fossa. This superficial fossa, it is the superficial fossa of the anterior abdominal wall. Just deep to the superficial fossa, there is a membranous layer of the superficial fossa, we call it fossa colis. These fossa colis and the superficial layer joined here and become muscular in the scrotum. And we call it dartos layer or dartos muscular layer. That's when this superficial layer, dot white and blue layer, fossa colis, they are mixed together, and in this here the smooth muscles are present. These smooth muscles we call dartos. And when it continues to the penis, again it becomes fossa and we call it fossa penis. And these fossa penis now continue like here, the superficial fatty layer known as the fossa of Camper and a membranous layer known as the fossa of Scarpa. This is the umbilicus, and above the umbilicus again 2 liters blend and become fatty layer, superficial layer. So above the umbilicus, it is the superficial fatty layer, superficial fossa. Below the umbilicus, these superficial fossa divided into fossa of Camper and fossa of Scarpa. In penis, these join together to form fossa penis. In scrotum, these form dartos muscle. Again in perineum, it spreads to the superficial fossa and the fossa colis. And above this fossa colis, there is another fossal layer, very strong fossal layer. It is the perineal membrane. Perineal membrane. This perineal membrane joined with the fossa calis, so it is closed posteriorly, but anteriorly it is open. Above this perineal membrane, this yellow is the perineal membrane. It cuts section, it looks like that, but in literally this is look like that. Perineal membrane. above the perineal membrane, previous view, there is another layer we call superior fossa of the urogenital diaphragm. কেন এই জিনিসটাকে আমরা আগে বলতাম, previously we call it this pouch, we call it urogenital diaphragm, containing muscles surrounding the urethra known as the sphincter urethrae. But nowadays there is no such muscle. Sphincter urethrae is present, but it is not outside the urethra, but present within the wall. Walletটাই ঠিক হয়ে গেছে, and we call it now distal urethral বা urethral mechanism বা sphincter urethrae চলতে পারে। এই পাউচটাকে আমরা বলতাম আগে urogenital diaphragm. So perineal membrane is equal to inferior fossa of the urogenital diaphragm, and above this layer we call the superior fossa of the urogenital diaphragm. And previous view is that this is anteriorly, this is attached with the air, and so this space is closed. But recent view is that there is no such fossa. Besides, there is a loose areolar tissue is present. We call it endopelvic fossa. Endopelvic fossa. And here lies the, above it in male, here lies the bladder and prostate. And this is the urethra passing in this fashion and passing this fashion. And here is the muscle levator ani or pelvic diaphragm. So you definitely look, there is two spaces. One is here, one is here. This lower space we call superficial perineal space or superficial perineal pouch. And above this, the deep perineal pouch. Because when we dissect, when the surgeon operation, it comes first, so we call it superficial, and it comes later, we call deep. So you can, by seeing this picture, you know the superficial perineal pouch or space is open anteriorly. It is open anteriorly, posteriorly it is closed. A deep perineal pouch, in recent view, it is closed anteriorly, closed posteriorly, but above it is open. But previous view that there is a definite fossa, so all the layer, this space is totally closed. But recent said it is open anteriorly. Why it is important? For clinical anatomy. I will come later on. Very interesting. And the urethra starts here, passing through the prostate, we call prostatic urethra. Then it passing through here, deep and superficial perineal pouch, we call membranous urethra. Then in the penis, the penile urethra. There are the parts of the urethra in male. Female, it is a very short, only 4 centimeters, straight one. So, one by one. So, it is the superficial perineal space or superficial perineal pouch. Description. তাহলে কি হলো যদি শর্ট নোট দেয় introduction. It is a space in the perineum, in the urogenital triangle. এরকম ভাবে প্রত্যেকটা দেখো আমি কিরকম ভাবে বাড়িয়ে দিচ্ছি just to lengthen my discussion. I know it is present here. So it is a space and pouch within the urogenital triangle of the perineum, bounded below by the fossa collis and above by the perineal membrane. Introduction শেষ. Next, boundary. Boundary, if you view the boundary, whenever anything, whether it is a deep perineal space, whether it is a superficial perineal space, whether it is a ischianal fossa, to know the boundary, you have to view 2 pictures here. Otherwise, in a same picture, same view, it is not possible to know the anterior, posterior, above, below, medial, lateral boundary. So we have to have a three-dimensional idea. So if we look this anterior boundary, it is shaped a superficial perineal space, obviously truncated, triangular. On each side, laterally, joint istiopubic rami. গেল? বোঝা যাচ্ছে তো? আমি এই পিকচারটা থেকে এখান থেকে এটা বুঝতে পারবো না, এই ভিউটা আসবে না। তাহলে অন ইচ সাইড apex is by joining it is bounded by the perineal body and joining of the fossa colis and the perineal membrane. এই দেখো, so posteriorly it is closed. Above, আবার এই পিকচার দেখতে হবে, it is bounded by the perineal membrane. Below, fossa colis. বাউন্ডারি শেষ। কন্টেন্টস, কিভাবে কন্টেন্টস গুলি আমরা ডেসক্রাইব করব? ওয়ান বাই ওয়ান। স্ট্রাকচারস, ইন মেল ফার্স্ট ক্লাসে আমি বলেছিলাম এই জায়গাটাকে যদি সুপার স্কিন কাটলাম, ফসা কলিস যদি কাটি, আমরা ঠিক এরকম দেখতে পাবো। Male, it is the conjoint isquiopubic rami. The penis, urethra comes here. Urethra comes passing through the deep perineal pouch, then enter the superficial perineal pouch, and here the urethra is dilated. We call bulb of the urethra. মনে পড়ছে? একদম প্রথম ক্লাসে বলেছিলাম urethra is dilated. আমরা যদি এখানটা দেখি, it is the bladder, it is the prostate, it is the liver or pelvic diaphragm, তারপর হচ্ছে perineal pouch, superficial perineal pouch, এই দিক দিয়ে চলে গেল স্ক্রোটামের দিকে, scrotum, penis. So it starts here, passing through the prostate, through we call prostatic urethra, then passing through the superficial and deep perineal pouch, we call it membranous urethra. This deep perineal pouch we call membranous urethra, and here urethra is dilated in the superficial perineal pouch. We call bulb of the urethra. কি বলি? Bulb of the urethra, bulber মতো. And this bulb of the urethra now continued as a penile urethra. So superficial perineal pouch এ আমরা urethra কোন পার্ট দেখছি? Bulb of the urethra. তাহলে এখানে bulb of the urethra in case of a male. Right? In female কি পাবো? Urethra and vagina. ফিমেলে urethra নেমেছে, vagina নেমেছে, ছেড়ে দাও। আচ্ছা, নেক্সট, এটা গেল স্ট্রাকচারস। নেক্সট, মাসেলস। What are the muscles present in the superficial perineal pouch? What are the muscles present in the superficial perineal pouch? Number one, তারপরে ফিমেলে সেটা লিখতে হবে, urethra and vagina. Three muscles. ও আর কি স্ট্রাকচার ভুল হয়ে গেছে, সরি। মেলসে আর কি পাবো? Bulb of the urethra, and on either side এখানে কি রয়েছে ক্রাস অফ দ্য পেনিস ক্রাস অফ দ্য পেনিস এইখানে একটা মাস্কুলার স্ট্রাকচার রয়েছে এই ইরেকটাইল স্ট্রাকচার রয়েছে তাকে অ্যাটাচ টু দ্য ইস্টিওপুবিক রামাই and when it continued anteriorly form corpora cavernosa of the penis. And when this bulb of the urethra continued, it called corpus spongiosum of the penis. So there is a two erectile structure present here. We call crus of the penis, plural crura of the penis. It is an erectile tissue. Come on. So এখানে crus of the penis or crura of the penis. আর এইখানে কি হবে ভ্যাজাইনা ইউরেথ্রা ভ্যাজাইনা অ্যান্ড ক্রাস অফ দ্য ক্লাইটোরিস ফিমেলের ক্ষেত্রে পেনিসটা ক্লাইটোরিস হয়ে যাবে ক্লিটোরিসও হয়ে যাবে মনে পড়বে ক্লাইটোরিস ওখানে আবার পেনিস লিখে দিও না নেক্সট মাসেলস four important muscles are present here. One covering the crus of the penis, which covers the crus of the penis, we call istiocavernosus, one on either side, and one cover bulb of the penis. We call bulbospongiosus. In female, bulb of the vestibule. In male, this bulbospongiosus is single. Right and left have joined together to form a single muscle, bulbospongiosus. In female, there is an cleft. In female, there is an cleft gap. So bulbospongiosus muscle is also divided into right half and left half. তাহলে ওখানে ওটা লিখতে হবে আচ্ছা এইটা গেল আর কি ইম্পর্টেন্ট মাসল রয়েছে there are another very important muscle which is present here from the posterior part of the conjoint ischiopubic rami one on either side and attached to the perineal body. Which forms the posterior boundary of the superficial perineal pouch. তখন বলিনি কেন কারণ এইটা আমি ডেসক্রাইব করিনি বলি so it forms the posterior boundary of the superficial perineal pouch. This muscle is transversely disposed, we call it transverse perini superficialis. Transverse perini superficialis. Which steadies the perineal body. Perineal body ke fixed rakhte helps. It helps the steady the perineal body. So these are the muscles present in the male: istiocavernosus, bulbospongiosus, transverse perini superficially. In female, istiocavernosus clitoris, bulbospongiosus, but two in number, right and left, and transverse perini superficialis. Next. Vessels. এবার ব্যাক করো তো what I have told in last class. The internal pudendal artery, first branch it gives in the istioanal fossa known as the inferior rectal artery. Then it proceeds and enter pudendal canal, it gives branches. What are the branches? Perineal branch, bulb of the penis, urethral artery, ভালো করে শোনো, deep artery of the penis, dorsal artery of the penis. These are the branches of the internal pudendal artery. And they give branches in the deep perineal pouch. দো সো এটা প্লিজ ভালো করে শোনো দ্য ফার্স্ট পার্ট স্টেম অফ দ্য আর্টারি স্টেম মানে কি ইনিশিয়াল পার্ট of these branches initial part of these branches means deep artery of the penis dorsal artery of the penis urethral artery vaginal artery আচ্ছা হ্যাঁ ইন ফিমেল এটা ভ্যাজাইনাল হবে ছেড়ে দাও urethral artery ভ্যাজাইনালটা বাদ দাও and কি বললাম artery to the bulb of the vestibule initial part in the present in the deep perineal pouch. All this artery must enter the superficial perineal pouch. To enter the superficial perineal pouch, it must pierce the perineal membrane. এই perineal membrane কে ওকে pierce করতে হবে। এটা pierce করছে করে enter the superficial perineal pouch. বুঝতে পেরেছো? It enters the superficial perineal pouch. তাহলে first part of the or stem of the artery is present in this deep perineal pouch and the main branches are present in the superficial perineal pouch. সুতরাং আর্টারিগুলো এখানে রয়েছে আর কি রয়েছে perineal branches আগেই বলেছিলাম perineal branch first branch দিচ্ছে perineal branches it gives of very important arteries two arteries on each side তাকে বলা হয় posterior scrotal artery or posterior labial artery in female তাহলে এখানে রয়েছে এইগুলি posterior scrotal artery deep artery of the penis dorsal artery of the penis urethral artery artery to the bulb of the penis সেই আর্টারিগুলি এই সব জায়গা দিয়ে পাস করছে তাহলে ইয়ে হয়ে গেল and corresponding vein নার্ভস পুডেন্ডাল নার্ভ আগেই বলেছি পেরিনিয়াল নার্ভ দেয় which gives to posterior scrotal nerve এইখানটায় থাকে so posterior scrotal nerve এছাড়াও দিচ্ছে dorsal nerve of the penis dorsal কোনো deep nerve of penis বলে কিছু নেই so these are the nerves present in the artery আরেকটা কি জিনিস আছে সুপারফিশিয়াল পেরিনিয়াল পাউচে যেটা মেলসে রয়েছে ফিমেলসে নেই ডাক্ট অফ বালবোইরেথ্রাল গ্ল্যান্ড এইবারে বলো there are two another important structure present in the male a female not in male corresponding to the bulbourethral gland greater vestibular gland so এইখানটায় স্ট্রাকচারে লিখতে হবে in female greater vestibular gland urethra vagina and greater vestibular gland and এইগুলি রয়েছে স্ট্রাকচার প্রেজেন্ট ইন দ্য superficial perineal pouch clinical anatomy very very important clinical anatomy urethra passing through the superficial perineal pouch please ভালো করে শোনো urethra passing through the superficial perineal pouch এখান দিয়ে urethra পাস করছে এখানে valve of the vestibule রয়েছে and it urethra রয়েছে and it sometimes it is damaged কখন ড্যামেজ হয় ইউজুয়ালি আগেকার যুগে যেটা বেশি ড্যামেজ হতো দেয়ার ইজ এন হাইড্রেন্ট ইন দ্য রোডস সো দ্যাট দ্য ম্যান ক্যান go inside this drain and clear this drain and it is covered by the round shaped cover very heavy cover sometimes it is loosely attached to this hydrant and sometimes if we put on this here it just revolve back and hit here বুঝতে পেরেছো কি একটা জিনিস প্ল্যাবের মতো রয়েছে এইখানটায় দিলে এটা উঠে এসে এইখানটায় লেগে গেল এখন ইট ইজ ভেরি রেয়ার ডেঞ্জারাস কি সাম ফল ফ্রম এ হাইট ট্রিজ গাছ থেকে পড়তে গিয়ে সাম ব্রাঞ্চেস হিট হিয়ার নিচে পড়ছিল এইখানটায় হিট করলো অ্যান্ড দেয়ার আর সামনে গিয়ে ধাক্কা মারলো এইখানে গিয়ে হুইলটা এসে লাগলো বা এনি স্ট্রাকচার সো দিস টাইপ অফ ইঞ্জুরি ফ্র্যাকচার দিস there is a tear of this urethra and urine comes out, and we call extravasation of urine. When urine comes out from the urethra, we call it extravasation of urine. This term, medical term, খেয়াল রাখবে, extravasation of urine. Urine. So, urine producing all time by the kidney. This extravasated urine cannot go posteriorly. Cannot. It is closed. Cannot go down. Closed. Cannot go up. Closed. But it can go anteriorly. So, urine comes out through this খুব ভালো করে শোনো, and enters the anteriorly enter the scrotum deep to the dartos muscle. দেখো ডার্টোসের ঠিক ডিপে দিয়ে যাচ্ছে, swell the scrotum, urine জমে যাচ্ছে deep to the dartos muscle, swelling the, so scrotum is full of urine deep to the dartos. খেয়াল রাখবে কথাটা কিন্তু এক্সামিনার দেখতে চাইছে, deep to the dartos muscle. সুপারফিশিয়াল হলে এইখানটায় হতো deep to the dartos muscle. Then it enters the perineum deep to the fossa penis and swell the penis. পেনিসটাও ফুলে গেল ইউরিনে, deep to the fossa penis. Then it enters deep to the fossa of Scarpa in the lower part of the anterior abdominal wall, in a space called, কালকে বলেছিলাম মনে রাখতে, superficial inguinal space, which is a space between the fossa of Scarpa and external oblique aponeurosis with its fossa. এইখানে রয়েছে external oblique aponeurosis with its covering fossa, and এই স্পেসটার নাম হচ্ছে superficial inguinal space. So urine fill this here. এইখানটায় ইউরিন এসে গেল, ইউরিন go up, go up, go up, go up. Then in above the umbilicus, it can go up deep to the superficial fossa. And theoretically, this urine can go up to axilla. But it is theoretically possible. Practically, it is not possible. Because axillary fossa is attached here, it cannot go beyond that. So, theoretically, deep to the superficial fossa, it can go up to the axilla. কিন্তু হয় না, কেন? তার আগেই পেশেন্ট শকে চলে যায়, ইউরিন বিকাম স্টপ, or patient takes to the hospital where the intervention done by doctors, অথবা patient died. সুতরাং এটা theoretically, literally up to this is possible, full of urine, right? But theoretically it can go up to the axilla, but ওখানে লিখে দিতে হবে, it is usually not possible. The urine cannot go to the thigh, cannot. Why? Because fossa of Scarpa attached to the fossa lata, so it cannot go the thigh. থাইতে যেতে পারবে না. So this is an interesting clinical anatomy of urethra in the superficial perineal pouch. Right? Clear? এটা অনেকবার পরীক্ষায় এসেছে. কেমন? Next. Deep perineal pouch. Deep perineal pouch is very easy. Already আমি কভার করিয়ে গেছি. Structures in male urethra, in female urethra and vagina. In male, there is another important structure present which is not present in female. It is the bulbourethral gland, Cowper's gland. Muscles. Muscles, previous view, boundary. Previous view, apex is in the inferior pubic ligament. Base is posterior border or base is formed by the perineal body and another muscle, both of a closing of the muscle, transverse. Anteriorly, it is closed by previous view by the apposition of the superficial and fascia of the urogenital diaphragm and the perineal membrane. Above, previous view by the superior fascia of the urogenital diaphragm. Okhane likhe dite hobe, but recent view, there is not such fascia is present. It is only covered by loose areolar tissue known as endopelvic fascia. So it is open superiorly. On either side, conjoint ischiopubic rami. হয়ে গেল boundary. Contents, structures in male urethra, in female urethra vagina. In male, another structure, a gland known as the bulbourethral gland. Corresponding gland is the vestibular gland, greater vestibular gland, present in the superficial fascia in case of a female. খেয়াল রাখবে, bulbourethral gland in male present in the deep perineal space, and corresponding female gland jeta greater vestibular gland present in the superficial perineal pouch or space. Yellow. Muscles. Previous view, the urethra is covered on all round by the sphincter urethrae muscle, which is a skeletal muscle. But recently, এটা লিখে দেবে, recent view, no such sphincter is present. This sphincter is present within the wall, within the layers of the wall of the urethra, and known as the distal urethral sphincter mechanism. প্রথম ক্লাসে খুব ডিটেইলসে বলিয়েছি, consisting of skeletal muscle fiber bracketed rhabdosphincter plus smooth muscle fibers, taking some fibers of the pubourethral part of the levator ani. এই তিনটে লাইন লিখতে হবে। কি লিখবে? Recent view is that sphincter urethra is present within the wall of the urethra. Components part is the skeletal muscle, smooth muscle, and pubourethral part of the levator ani. In female, there are two additional muscles are present, compressor urethrae and sphincter uretrovaginalis. বাস লিখে মুখস্থ করে বেরিয়ে যাবে, এক্সামিনার ভাবে ইউ নো এভরিথিং, কিচ্ছু ডিটেলস পড়ার দরকার নেই। কোথায় কম্প্রেসর ইউরিথ্রি গেছে, কোথায় স্ফিংক্টার গেছে জানার দরকার নেই, শুধু নামগুলি মনে রাখবে, মুখস্থ করবে 15 বার করে। ডিস্টাল স্ফিংক্টার ইউরেথ্রাল মেকানিজম ইন ফিমেল, কম্প্রেসর ইউরিথ্রি অ্যান্ড স্ফিংক্টার ইউরেথ্রোভ্যাজাইনালিস। দয়া করে মেলের ক্ষেত্রে স্ফিংক্টার ইউরেথ্রোভ্যাজাইনালিস লিখবে না, কারণ মনে থাকে যেন। তাহলে এই মাসেল রয়েছে। আর কি মাসেল রয়েছে? লাইক there is a muscle present in transversely from the ischiopubic rami to the perineum, which is called the fundus. Nerves ki present? Vessels, internal pudendal artery, and stem of the branches of the internal initial part, urethral artery, artery to the bulb, deep artery, and dorsal artery. First part ta এইটুকু ওই ছোট ছোট ইনিশিয়াল পার্টগুলি রয়েছে। নার্ভ রয়েছে, ইন্টারনাল পুডেন্ডাল নার্ভ অ্যান্ড posterior initial part of the posterior scrotal nerve। বাস ছেড়ে দাও, আর কিচ্ছু দরকার নেই। তাহলে ডিপ পেরিনিয়াল পাউচ এর যদি এখানে যদি ইম্পর্টেন্ট, তাহলে আমাদের এটা শেষ হয়ে গেল পেরিনিয়ামের ইউরোজেনিটাল ট্রায়াঙ্গেল। superficial perineal space, boundary contents applied, deep perineal pouch, boundary contents and few applied. But next going to the this part, very important, istioanal fossa. This is the anal triangle anteriorly bounded by the perineal body and the imaginary line, kalpona korechi, interistitial line. Laterally istial tuberosity, posterolaterally sacrotuberous ligament. This is known as the sacrotuberous ligament, a ligament from the istial tuberosity to the sacrum. Sacrotuberous ligament and posteriorly tip of the coccyx and lower part of the sacrum. So this is the boundary of the anal triangle. And each anal triangle in the midline, by the anus, is divided into two parts. This is known as the istioanal fossa. কি বলা হয়? Istioanal fossa. এটা মুছে দিচ্ছে এখন। হিস্টোলজিটা ভাবো, তারপরে রয়েছে সাবটিউবুলার, এটা হচ্ছে রেকটাম। ক্যানেলের লেন্থ কি কি তিনটে ভাগ আছে পড়েছো তো, আপার পার্ট, মিডিল পার্ট অ্যান্ড লোয়ার পার্ট পড়োনি? আপার পার্ট 15 millimeter, middle part or transitional zone 15 millimeter, lower line by skin 8 millimeter. মনে রাখতে হবে লেন্থ গুলি। It is the upper part and lower part. It is lined by skin. It is lined by skin. মেমব্রেনের পরে কি থাকে? সাবমিউকোসা। আমাদের এইটা কত হিস্ট্রি, সাবমিউকোসা। সাবমিউকোসার পরে থাকে মাসকুলার এক্সটার্না, কনসিস্ট অফ স্মুথ মাসল অ্যান্ড আউটসাইড লঞ্জিটিউডিনাল মাসল। তাহলে এখানে স্মুথ মাসল আমি আঁকি, the smooth muscle of the anal canal is thickened to form a sphincter known as the internal anal sphincter or sphincter ani internus, common name. এইখানে কি smooth muscle has got a two part, circular muscle and outside longitudinal muscle. আমরা হিস্টোলজিতে পড়েছি। This circular muscle is very much thickened here and form a sphincter. Smooth করলে কন্ট্রোল আর রিল্যাক্স করলে খুলে যাবে। And this is known as the sphincter ani internus. কেন এটা উইদিন দ্য ওয়ালে থাকছে, sphincter ani internus. এইখানে আরেকটা মাসল রয়েছে, পেলভিক ডায়াফ্রাম লিভেটার ani, which is যে কোনো মাসল covered by a fascia থাকে, superior fascia of the levator ani আর inferior fascia of the levator ani। এই inferior fascia of the, ভালো করে শোনো এটা, any muscle, বারবার বলি আমি, it is covered by a fascia, so it is the levator ani muscle or pelvic diaphragm, এরকম করে পেলভিসের মধ্যে রয়েছে levator ani muscle। It is covered by a fascia, superficial fascia of the pelvic diaphragm and inferior fascia of the pelvic diaphragm। এই inferior fascia of the pelvic diaphragm এর আরেকটা নাম রয়েছে, সেটাকে আমরা বলি anal fascia। So anal fascia is equal to inferior fascia of the pelvic diaphragm or levator ani। একদম ল্যাটারালি কি রয়েছে, ischial tuberosity and ischium। তাকে বলা হয় obturator muscle। এটা হচ্ছে লিভেটার অ্যানাই, এটা হচ্ছে obturator internus muscle। It is covered by a fascia। কেমন এরপরেটা, আচ্ছা এটা গেল স্ফিংটার অ্যানাই এক্সটার্নাল স্মুথ মাসল ইজ থিকেন টু ফর্ম দ্য স্ফিংটার অ্যানাই ইন্টারনাল। এটা রাখছি আমি। এরপরে as there is an sphincter ani internus, there is an another muscle present outside the anal canal which is called the sphincter ani externus। It is a totally skeletal muscle। So outside there is previous view is that সবসময় এগুলি খুব চেঞ্জ হয়েছে, মানে রিসেন্ট চেঞ্জ হয়েছে। প্রিভিয়াস ভিউ ইজ দ্যাট দ্য স্ফিংটার অ্যানাই ইন্টারনাস ইজ এক্সটার্নাস, সরি এইটাকে টোটালটাকে বলা হয় স্ফিংটার অ্যানাই এক্সটার্নাস ইজ কম্পোজড অফ 3 গ্রুপস অফ মাসল, সাবকিউটেনিয়াস পার্ট, সুপারফিশিয়াল পার্ট অ্যান্ড ডিপ পার্ট। সাবকিউটেনিয়াস পার্ট, এটা স্কিন রয়েছে, অ্যানাসের স্কিনটা, subcutaneous part, superficial part and a deep part। Subcutaneous part, superficial part and deep part, sphincter ani externus, supplied by the perineal nerve and S4 nerves, nerve supply রয়েছে। কিন্তু রিসেন্ট বলছে এরকম কোনো ডিভিশন নেই। দেয়ার ইজ এন টু একটাই মাসেল, সুপারফিশিয়াল অ্যান্ড ডিপ। আমরা পুরনো মেথডটাই রাখি সুবিধা। এটা গেল সাবকিউটেনিয়াস পার্ট অফ দ্য স্ফিংটার অ্যানাই এক্সটার্নাস, সুপারফিশিয়াল পার্ট অ্যান্ড ডিপ পার্ট। নাও রেকটামের কি মাসেল কমপ্লিট হলো? স্মুথ মাসেল বলেছি, লঞ্জিটিউডিনাল মাসেল রয়েছে। দেয়ার ইজ এন লঞ্জিটিউডিনাল মাসেল, মাসকুলারিস এক্সটার্না মিন্স ইনার স্মুথ, আউটসাইড লঞ্জিটিউডিনাল মাসেল। সো রেকটামেও একটা লঞ্জিটিউডিনাল মাসেল রয়েছে। খুব ভালো করে শোনো এটা। Now, few fibers of the levator ani, pubo rectal part or puboanal part of the levator ani joined with this muscle of the longitudinal muscle coat of the rectum. Please এটা ভালো করে শোনো লাগবে. Few fibers of the puborectal part or puboanal part of the levator ani. মনে পড়ছে levator ani has got three component, pubourethral, puboanal, তারপরে হচ্ছে ischio এই iliococcygeus part. A few part of the pubourethral part joins with the longitudinal muscle coat of the rectum and anal canal and goes down, and here it is replaced by a muscle হয়ে গেল, no muscle in the lower part, and we call it conjoint fibroelastic septa. And in the lower part of the anal canal, it splits into a number of এদিকেও রয়েছে and branches attached to the skin around the anus. এইটা হচ্ছে anal canal, এইটা হচ্ছে anal canal outside যেখান থেকে স্টুল বেরিয়ে আসছে, এটা হচ্ছে anal canal. And when it contracts or due to this pull, you can feel when you pass your finger around your anal canal, there is an corrugation. উঁচু corrugated টিনের মতো corrugation রয়েছে আর anal canal সবারই. সুতরাং এইকে বলা হয় corrugator cutis ani. corrugator cutis ani. So corrugation মানে কি এরকম তুমি দেখবে চারপাশে এরকম রয়েছে, এই স্লাইটলি উঁচু ডিপ্রেশন, সুতরাং এইগুলিকে বলা হয় corrugator cutis ani. cutis means skin, corrugation মানে উঁচু নিচু, কেন নাম আসছে এই জিনিসকে বলে corrugation. And one of the septa, খুব ভালো করে শোনো, one of these lateral septa goes here directly to go to the pudendal canal. It is the pudendal canal, and it is known as the very important, এটা লাগবে আমার, perianal fascia. ওটা ছিল anal fascia, এটার নাম হচ্ছে perianal fascia. Perianal fascia is nothing but the fibroelastic septa from the longitudinal muscle of the anal canal and levator ani goes laterally to attach to the fascia covering the pudendal canal. So it is known as the perianal fascia. কেমন কি বলছে perianal fascia? শেষ হলো না, প্রায় শেষ. There is another fascia starting from this here and so there is another fascia, violet দিয়ে লিখেছি, arching measure, এইটাকে বলা হয় lunate fascia. সুতরাং এই ফাসাগুলির নাম আমাদের জানতে হবে. তাহলে কি কি fascia? Anal fascia, which covers the lower part of the levator ani. Lunate fascia, এটা হচ্ছে obturator internas with this fascia, আর এটা হচ্ছে perianal fascia, এটা হচ্ছে skin. This is the anal canal. So these one on the other side of the space, it is the space, এখানেও রয়েছে এইখানটায়. This space is known as the ischio-anal fossa. Ischio-anal fossa. আগে বলতে ischio-rectal fossa. Actually, it is present in the lateral part of the anus canal, not on the rectum. So it is called the istioanal fossa. So by this, istioanal fossa is a space on either side of the anal canal in the anal triangle of the perineum. Boundary. Who is he? Anterior boundary, perineal body and istio line. Posteriorly, sacrotuberous ligament and tip of the coccyx. Laterally, ischial tuberosity. Na, bhul bolchi, sorry. Lateral boundary is formed by the obturator internus with its covering fascia and lower part of the ischial tuberosity. এখানে আমি শুধু ischial tuberosity দেখতে পাচ্ছি। তার জন্য আমি বলে দিয়েছিলাম পুরোটা দেখতে গেলে তোমাকে এই coronal section লাগবে। এখানে শুধু ischial tuberosity লেভেলে আমি কেটেছি transversely. So lateral boundary is formed by the obturator internus with its covering fascia and medial surface of the ischial tuberosity. This is the lateral boundary. Medial boundary, anal fossa and the sphincter ani externus. দেখো পরিষ্কার নিজেই বলতে পারছি। So anal fossa, and it is the fossa covering the sphincter ani externus and the fossa covering the sphincter ani externus. This is the medial boundary. এই টোটালটা হচ্ছে medial boundary, এটা হচ্ছে lateral boundary. Lateral boundary হচ্ছে obturator internus with its covering fossa above and ischial tuberosity below. Medial boundary above by the anal fossa and below by the fossa covering the sphincter ani externus. Base is formed by the skin. Base is formed by the skin. এই জায়গাটা আমাদের skin. And apex is formed by the joining of the obturator fossa and the anal fossa. এই যে apex. Division of the istioanal fossa. খুব ভালো করে শোনো। This is the lunate fossa. And highest point of the lunate fossa we call tegmentum. The highest point of the lunate fossa ke amra boli tegmentum. Amra boli tegmentum. Ki boli? Tegmentum. So the part of the anal fossa, istioanal fossa above the tegmentum, we call it suprategmental space. Supra means above. Suprategmental space. And below is known as the infrategmental space, which is again divided by the perianal fossa. এই বড় স্পেসটাকে বলা হয় istioanal fossa. এই istioanal space. And এইটাকে বলা হয় below the perianal fossa perianal space. এইটা হচ্ছে suprategmental space. তাহলে istioanal fossa divided into three parts: suprategmental space, istioanal space and perianal space. Why this different? Different is very important. কেন বলে দিচ্ছি, একটা clinical anatomy. This space, perianal space, is full of fat. And this fat is present as a loculi. ছোট ছোট loculi দিয়ে রয়েছে। এই ফ্যাটগুলি ছোট ছোট পকেটসের মধ্যে রয়েছে, কমপ্লিট পকেট। সো ইফ এনি ইনফেকশন, অ্যান্ড ভেরি কমন, বুঝতেই পারছো অ্যানাসের পাশে রয়েছে সো মেনি ব্যাকটেরিয়া, সো দিস পার্ট ইজ গেটস ইনফেক্টেড ভেরি অফেন। এই পর কি হয়েছে, ছোট ছোট পকেটে রয়েছে, কমপ্লিট এরম ভাবে রয়েছে। সো ইনফেক্টিভ মেটেরিয়াল অ্যাকুমুলেটস হিয়ার and it tries to give pressure on the wall, but it cannot burst open because it is completely surrounded by the strong septa, complete septa, so that pressure within this loculi is very much increased, irritating the nerves here, so causing tremendous pain. So if there is an infection বা এখানে যদি কোনো অ্যাবসেস হয়, it is very painful, প্রচন্ড পেইনফুল। কারণ ছোট লোকুলি রয়েছে, ইট ক্যানট এক্সপান্ড। এক্সপান্ড করলে কি হতো, প্রেশারটা কমে যেত। আমরা যদি একটা এইটুকুনি জায়গায় রাখি বেলুনে, ছোট্ট বেলুনে জল ভরে রাখি, বেলুনটা যদি আমরা প্রচন্ড প্রেশার, বড় বেলুনে ওই জলটা ভরে দিলে প্রেশারই নেই। সো ইরিটেটিং দ্য নার্ভস হেয়ার, নার্ভসের উপরে প্রচন্ড চাপ দেয়, কজিং সিভিয়ার পেইন। বাট ইন দ্য ইস্চুয়ানাল ফেজ দেয়ার ইজ এ লার্জ লোকুলি অ্যান্ড ইনকমপ্লিট। এরকম if there is infection here, it can spread to a larger space, less pressure, less irritation to the term, so pain is less. সুতরাং এইখানে পেইন খুব বেশি হয়। It is one of the important what are the আর এখানে কন্টেন্টস খুব একটা বেশি নেই। আগেই বলেছিলাম pudendal artery gives a branch, inferior rectal vessels. Pudendal nerve gives a branch, inferior rectal nerve. বলেছি কি, এই inferior rectal nerve and inferior vessel এইখান থেকে বেরিয়ে এইরকম ভাবে আর্চ ম্যানারে থাকে। So contents is the inferior rectal vessels and nerve, perennial branch of the S4 nerve, perforating cutaneous branch of the S2, S3 nerve, and anal canal and fat. আরেকটাই রয়েছে applied, time আছে 1 minute. If this space is infected, full of pus, and পাসের নিয়ম হচ্ছে try to go যেখানে less pressure রয়েছে। সুতরাং this pus can track through here anal canal, এখান দিয়ে বেরিয়ে গেল, কারণ এই অ্যানাল ক্যানেলে প্রেশারটা লেস, and we call fistula in ano, we call fistula in ano. একটা এই যে ট্র্যাক্ট হয়, যখন ট্র্যাক্ট হয় একটা ক্যাভিটি থেকে আরেকটা ক্যাভিটি, তাকে বলি আমরা ফিস্টুলা। এটাই হচ্ছে ফিস্টুলা ইন অ্যানো ইন্টারনাল, কারণ এটা ইন্টারনালি ওপেন করেছে। সামটাইমস ইট মে ওপেন দ্য স্কিন এক্সটার্নাল। সো অনেক সময় না করলে আবার হবে, ব্লক হয়ে গিয়ে। সো দিস ইজ নোন অ্যাজ দ্য ফিস্টুলা ইন অ্যানো। সো এখান থেকে পেরিনিয়াম থেকে extravasation of urine, explain why fistula in ano and why perianal infection is so painful. এই তিনটে explain why question আসবে। Ischoanal fossa important for short notes. Boundary contents applied. কেমন? তাহলে আমরা শেষ করলাম abdomen, perineum.
Then what is the role of surfactant in our alveoli? কি কাজ করে alveoli? সারফেক্টেন্টের কিছু কম্পোজিশনস আছে, হ্যাঁ, তো মিনস কি না, কি লিপিড এগুলো, লাইপোপ্রোটিনস, হ্যাঁ, দিস লাইপোপ্রোটিনস হেল্পস কি করে, রিডিউস দ্য সারফেস টেনশন বাই হাউ, শিখেছিলাম না কি, আপওয়ার্ড ডিরেকশনস। যদি আমার এখানে পুশ এগেন একে এই জায়গাগুলো পুশ, তার মানে that is the surface tension, the exertions, that means collapsing. That's why the term is collapsing pressure. And so that after the addition of surfactantটা তখন এইখানে চলে আসবে, এইগুলোতে চলে আসবে, and that pull upward directions for the prevention for the collapsings. And this surfactant is used for the decrease the surface tension. Now what is the relation of surface tension, pressure, radius? কি পি, এই পিটাকে কি বলা হয়, কি প্রেশার? নো অ্যালভিওলার প্রেশার, দিস ইজ নট অ্যাট অল অ্যালভিওলার প্রেশার। আমি এটাই দেখছি আর কি, যে কোলাপসিং প্রেশার। সো কোলাপসিং প্রেশার অফ অ্যালভিওলার, দিস ইজ কল্ড কোলাপসিং প্রেশার। শিখবি তো, ভালো করে শিখবি, নইলে শেখার কোনো দরকার নেই। equal to T means surface tension by, it is radius or the resistance? Radius. Now, why it is important? Why this is important to T by R? Why it is important? What is the law named? Key law bole etage? Laplace law. So respiratory system is basically a physics, nothing else. Pressure থাকবে, ভলিউম থাকবে, গ্রেডিয়েন্ট থাকবে, প্রেশার গ্রেডিয়েন্ট থাকবে, ভলিউম প্রেশার চেঞ্জেস থাকবে। Alveolar pathology, why? When the air is stopped, static for static. What do you mean by dynamic? Air moving means airways will come into actions. So any diseases are associated with alveolar pathology, that means some static compliance is essential, and the formula is, yes, plateau pressure. Very good. So plateau pressure minus positive n expiratory pressure, n expiratory pressure, PEEP. These are important. And dynamic is for the PIP minus peak inspiratory pressure. And always remember, PIP, that is peak inspiratory pressure, is more এটার মধ্যে কি dynamic always less, dynamic compliance will be always less than the static compliance. তাহলে explain হয় যদি আসে, তখন পড়বো, আকাশ থেকে পড়লো, খুব কঠিন। এই কথাটা লিখলে যদি 5 নম্বর থাকে তাহলে 5-এ 5 পাবে, আর যদি লিখতে না পারিস জাস্ট 0 পাবে। ওকে, সো পিক ইন্সপিরেটরি প্রেশার, আগের দিনকে ছবি এঁকে so this is a peak and this is the plateau. এই এরিয়াটা হচ্ছে প্ল্যাটু। প্ল্যাটু মানে কি? প্ল্যাটু। So static compliance is for the alveolar pathology, means কোনো একটা নিউমোনিয়া হয়েছে, নিউমোনিয়াতে আমার alveolar pathology is going on, and that's why you have to think about the compliance কি হচ্ছে পেশেন্টের, কেন জানা দরকার, ট্রিটমেন্টের জন্য জানা দরকার। নইলে কোনো ব্যাপারে না জানলে হলো, অক্সিজেন দিলেই যে হয় না, সেই জানাটা আইডিয়াটা দরকার, যে একটা রেসপিরেটরি ডিস্ট্রেসের পেশেন্টকে শুধু অক্সিজেন দিলে হয় না, আদার্স প্যাথোলজি জানতে হয়। ইউ হ্যাভ টু আন্ডারস্ট্যান্ড হোয়াট ইজ গোয়িং অন, what kind of pathology, where is the site of infection, where it is the pathology is important. You have to understand that. Day by day you will gain that knowledge. Where it is the pathology, where it is the problem, problemটা কোথায়। So superficial knowledge is dangerous in nowadays, dangerous. So these things are basic things, are collapsing pressure, Laplace law, compliance, this surfactant. Why in case of preterm delivery the chances of respiratory distress is high? In case of preterm newborns, why there is a chance of respiratory distress? Patient come out in mother's womb, then presented to me that with the severe respiratory distress is a premature baby. That may not be premature baby, but mostly the premature baby come with respiratory distress. Why? Less secretion of surfactant or the less maturation of the pneumocytes? Less maturation of the pneumocyte. Developmentally, they are not up to the date, and so that the maturation of the pneumocytes type 2 cells are immature, so the less amount of surfactant is released. If surfactant is not helpful, then this upward pulling force will be like that. Collapse মানে টেনে নিচ্ছে এরকম, collapsing pressure will be high. তাহলে টি টেনশন যদি কম থাকে, collapsing pressure কি হবে? কমে যেতে পারে। আর রেডিয়াস যদি বাড়ে তাহলে কমে যেতে পারে। সো দিস থিংস এ কোলাপসিং প্রেশার বাড়বে না কমবে, কোন সময় বাড়বে, কোন ডিজিজে বাড়বে, কোন প্যাথোলজিতে ইনক্রিজ হবে, কোন ডিজিজে ডিক্রিজ হবে, ডিজিজ লিখবি, প্রবলেম লিখবি, এই হবে সেক। ডিজিজের মধ্যে কি কি মোটামুটি যেগুলো তোদের জানা কথা, এমফাইসিমা, পালমোনারি ফাইব্রোসিস, নিউমোনিয়া, পালমোনারি ইডিমা, হ্যাঁ, bronchial asthma, bronchiectasis, bronchiolitis, bronchitis. বুঝতে পারছিস? So these things are another questions were discussed, that why in case of bronchial asthma it is not bronchiolar asthma, as well as is called bronchodilatations, not bronchiolar dilatations, because already explained that the radius of the bronchus is single, but radius of the bronchiolar as a whole you have to take in. Then the flow, come into flow. Flow means what? Flow equal to P. P by resistance. Resistance by R. Then if resistance is increased, then flow will be decreased. In case of bronchial asthma, then what is the problem of bronchial asthma? Bronchiolar or bronchial? Bronchial means bronchus. Have you any idea about the bronchus? Ball, yellow color. Bolo, what do you mean by bronchus and what do you mean by bronchioles? Then the radius of the bronchus is more or bronchioles are more or less? Then from by using this formula, what can you expect? That the flow is more in bronchus or more in bronchioles? More in bronchioles. That is the concept. This is the concept. Sit down, sit down. So whenever we are dealing a bronchus, then the single radius is enough. Single radius is enough. But whenever you are considering the bronchioles, then the bronchioles altogether, summation of the radius is important. That is the main thing. That means R1, R2, R3, R4 smaller. Near bronchioles. Now you can tell me the radius of bronchus is more or bronchiole is more? Bronchioles are more. So if radius of bronchioles is more, then the resistance is less. If resistance is less, then the flow is much more. Simple. But in case of bronchial asthma, ultotai hobe. So bronchial asthma, it is termed as bronchial asthma, not bronchiolar asthma. What do you mean by asthma? Bronchial asthma nowadays it is called কি বলা হয় এখন একে? Reactive airway disease, RAD. So nowadays it is called reactive airway disease. Genetic disease, it is not curable, but it is controllable. এটাকে কিওর করা যায় না. If any clinician or any physicians can tell you that the asthma can be cured, that is a false. That cannot be cured because this is a genetically determined. Most family history is good there, and so that this can be controlled by different types of bronchodilator, long-term, short-term, as well as inhalatory steroids, and you always use the inhalers, not only the drugs like the syrup, etc. Is the inhaler is the main choice. Now my question is now new part is that Diffusion perfusion ratio. Already I described that. Perfusions, volume, perfusion. What do you mean by perfusion? What do you mean by oxygenation? What do you mean by ventilation? What is the difference between the ventilation and oxygenation? তাহলে ventilation কি হলো? We are taking in air, then ভেতরে আমার gaseous exchange, where alveolar and pulmonary capillaries surface exchange, then out of what? Carbon dioxide. এটাকে বলছি ভেন্টিলেশন। সিট ডাউন। অ্যান্ড হোয়াট ডু ইউ মিন বাই অক্সিজেনেশন? Only adding of oxygen. So oxygenation does not the similar term of the ventilations. And ventilation perfusion ratio is now very important than the individual ventilation and individual perfusions. Pressure law, compliance, ventilation perfusion ratios. Why ventilation perfusion ratio? কোথায় বেশি, অ্যাপেক্সে না হচ্ছে ইয়ের বেশি? Everything you have to determine. Now you tell me, what are the exchange, gaseous exchange? Where is the place and what are the আমার কোথেকে আসছে? এটা রাইট ভেন্ট্রিকল থেকে আসছে। কি হিসাবে আসছে? ভাব পুরো জিনিসটা। রাইট ভেন্ট্রিকলস, ছবির মতো ভাববি। রাইট ভেন্ট্রিকলস থেকে পালমোনারি টাং বেরোচ্ছে, হ্যাঁ? দেন পালমোনারি টাং, রাইট অ্যান্ড লেফট পালমোনারি আর্টারিজ। পালমোনারি আর্টারি মিনস কি? অক্সিজেনেটেড ব্লাড না ডিঅক্সিজেনেটেড ব্লাড? ডিঅক্সিজেনেটেড ব্লাডটা কোথেকে এলো? ডিঅক্সিজেনেটেড ব্লাডটা ইনফিরিয়র ভেনা কেভা, সুপিরিয়র ভেনা কেভা থেকে রাইট এট্রিয়ামে এসেছিল। Then it comes to the right ventricle, then it goes to the pulmonary tongue, and then divide into pulmonary artery, and then pulmonary artery. তাহলে এইটা হচ্ছে, আর এখান থেকে এটা বেরোলো। এটা আমি ধরে নিলাম এটা রাইট ভেন্ট্রিকল, ওকে? তাহলে এটা পালমোনারি টাং হিসেবে আসছে। এখানে কোনো কনফিউশন আছে? নেই। এটা আবার কি করছে না, পালমোনারি, এটা পুরোটা ক্যাপিলারিতে যায়, and then these are coming as a কি, পালমোনারি ভেন। কোথায় পালমোনারি ভেনটা আলটিমেটলি? হ্যাঁ, রাইট এট্রিয়াম, লেফট এট্রিয়ামে আসবে। তাহলে আমার একটা আবার এইদিকে একটা হাত নিলাম, এখানে এটাই হচ্ছে, আর তো কিছু হচ্ছে না, আর তো কিছু করণীয় কিছু নেই এটার। These things are happening here for the exchange of gases. Why it is important? Respiratory system এটাই তো ইম্পর্টেন্ট। কেন ইম্পর্টেন্ট? For the gaseous exchanges. Why? Because we need oxygen. What does it mean? Partial pressure oxygen must be at the fixed level for to get the saturation level 100% বা more than 95 to 100%. সেটাকে বলা হয় SpO2 বা SO2, তাই তো? স্যাচুরেশনটা আলাদা, SpO2 বা SaO2. This is mostly 95 to 100% is a normal. এই যে আমাদের কোভিডের সময় whenever you are dealing with the pulse oximeter, what does it mean? Heart rate and this SpO2. If SpO2 less than 90, we become alert. What is happening? That means what? Alert means what? This is decreasing. That means partial pressure of O2 is decreasing. Partial pressure of where? Partial pressure of blood. Partial pressure in the arterial blood is going down and down and down. Why it is going? What was happening in the COVID is a problem in the exchange transmission due to different reasons. That viral, inflammatory reactions. This is space I like to highlight if time permits. कोई आज के ये नहीं रे घोड़ी टप पढ़ती था मुझे। So whenever you are dealing any exchange, gaseous exchange, always try to write out a flow chart, flow diagram like that. এবার আমাকে যদি এখানে কনসেন্ট্রেট করতে হয়, এখানে দু তিনটা জিনিস আমাকে ভাবতে হবে। কি ভাবতে হবে? এখানে তাহলে কি আছে? আমার এখানে বিভিন্ন অ্যালভিওলার সেলসগুলো আছে তো? দিস ইজ অ্যালভিওলাই, হ্যাঁ? এখানে অ্যালভিওলার সেল, এখানে অক্সিজেন আসে আর এখান থেকে কার্বন ডাইঅক্সাইড যায়। আমি লাংসের প্যারামিটারস, লাংস রিপ্রেজেন্টেটিভ ওয়ান অ্যালভিওলাস। অ্যালভিওলাটা থাকে surface area is large, so that gaseous exchange must be faster increase. Now this layer is coming, এখানে একটা লেয়ার আছে, আবার এখানে একটা লেয়ার আছে। কি এগুলো? এন্ডোথেলিয়াল সেলস, তাই না? এগুলো এন্ডোথেলিয়াল সেলস তো। আমি আর আঁকলাম না, তো সব এগুলো এন্ডোথেলিয়াল সেলস। এই মাঝেও একটা জিনিস থাকে, কি কি বলে সেটাকে, এই মাঝেও একটা জিনিস থাকে, হ্যাঁ বল, বেসমেন্ট মেমব্রেন বা বেসাল ল্যামিনা। So if anyone can ask you that respiratory membrane, what do you mean by respiratory membrane? Respiratory membrane means এইটুকু বলতে হবে alveolar cells type 1 type 2, basement membrane বা basal lamina and endothelial layer or endothelial cells of the pulmonary circulation. Finish. তাহলে that is called respiratory membrane. Because this basement membrane helps to detect the clear cut diffusion of the gases. এখানে কি হয়, up to depth 760 millimeter of Hg, এটা কি atmospheric pressure, কোথা থেকে এলো, due to some gases, কি কি সেই গ্যাস, নাইট্রোজেন, ভেরি গুড, এর partial pressure of this is equivalent to atmospheric pressure. Any confusion about that? The atmospheric pressure is coming for the different gases partial pressure additions. Nitrogen ये কত জানা আছে, percentage না, partial pressure probably 597, exactly আমার মনে পড়ছে না, 96 কি 95 এরকম। অক্সিজেন কত 159 সাব মিলিমিটার অফ Hg তে আছে। কার্বন ডাইঅক্সাইড কত 0.3, ওয়াটার কত 40। এই যোগ করলে ইয়ে কত দেখতো, কত কি আসছে, কাছাকাছি কিছু আসছে দেখতো, ফাইন ঠিক আছে। তাহলে এখানে কিছু একটা আছে, 69 বললি তো, তাহলে আমাকে 9টা বাদ দিতে হবে, এখানে একটু কমিয়ে রাখি 5 করে দিলাম, আর এখানে হবে, এবার হবে। Anyway, the concept is that, not the value, concept is that atmospheric pressure is equal to summation of partial pressure of nitrogen, oxygen, carbon dioxide and moisture or water. Finish. At 159 partial pressure of oxygen বাইরে আছে, এই যে এখন আছে, ঘুরছে এখন, আমি এটা ইনহেল করছি, তুইও করছিস, সবাই করছে। আর কার্বন ডাইঅক্সাইড কত নিচ্ছি 0.3 এয়ারে আছে, সেখান থেকে আবার নিচ্ছি। তাহলে যখন আমার অ্যালভিওলার কাছে গেল, তখন আবার পার্সিয়াল প্রেশার অফ অ্যালভিওলার O2 হয়ে যাবে 104, আর PaCO2 হয়ে যাবে 40 মিলিমিটার অফ Hg। এটা কেন হলো, 159 থেকে 104 হয়ে গেল কেন, তার কারণ ডিউ টু দ্য গোয়িং টু দ্য কন্ডাক্টিভ সিস্টেম, ইউজ করতে 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 গেছে, ডে স্পেস নিয়েছে, নষ্ট হয়েছে নানানভাবে। So that's why this is happening 104. And what is that 40? Due to the exchange. তাহলে এক্সচেঞ্জের সারফেস হচ্ছে রেসপিরেটরি মেমব্রেন। কি কি আছে, alveolar cell type 1 type 2, basement membrane বা basal lamina and endothelial cell of the pulmonary capillaries. Simple. Gaseous exchange, and this is the important site for the whole of the respiratory system. Respiratory system এর আমরা যা ভলিউম, কাফ, প্রেশার যা যা বলছি, to get the proper ventilation perfusions and to get the actual partial pressure of O2, to maintain the partial pressure of O2 in our blood, তাই তো। তাহলে এখানে গেল 104, এখানে এলো 40, এইটুকু এখন মনে রাখ। এইখানে যেটা আসছে, কি আসছে, এটা পালমারি আর্টারি। এটা কি আছে বাবু, পালমারি আর্টারি। কোথেকে আসে, রাইট ভেন্ট্রিকল থেকে আসে। তাহলে এখানে এটা ডিঅক্সিজেনেটেড ব্লাড না অক্সিজেনেটেড ব্লাড, ডিঅক্সিজেন, তাহলে ডিঅক্সিজেন দ্যাট মিনস অক্সিজেন পার্সিয়াল প্রেশার কম হবে না, কম হবে না বেশি হবে, কম হবে। তাহলে এখানে কত মোটামুটি জানা আছে, অত বেশি থাকে না 40, হ্যাঁ। আর পিএ CO2 কত থাকে, এটা বেশি থাকবে 45 to 46। তাহলে কি কি জানলাম এতক্ষণ পর্যন্ত? জানলাম অ্যালভিওলারের পার্সিয়াল প্রেশার অফ O2 and CO2, জানলাম কম্পোনেন্টস অফ আওয়ার রেসপিরেটরি মেমব্রেন, আর জানলাম পালমোনারি আর্টারির পার্সিয়াল প্রেশার অফ O2 and CO2। এইটুকু জানা আছে। এখানে কোনো কারো ডাউটস আছে? কিছু ডাউটস নেই। এখানে দেখ, এটা 40 হয়ে গেছে আর এখানে 104 আছে। এইবারেতে ইম্পর্টেন্ট থিওরি দ্যাট ইজ কল্ড হেনরিজ ল, যে ম্যাগনিটিউড অফ দ্য প্রেশার গ্রেডিয়েন্ট ইজ ইম্পর্টেন্ট ফর দ্য গ্যাসিয়াস ডিফিউশন। কি জিনিস না, লো প্রেশার গ্রেডিয়েন্ট থেকে কি, তাই কি হাই প্রেশার গ্রেডিয়েন্ট থেকে লো প্রেশারে যাবে। তাহলে আমার যদি এখানে 104 থাকে আর এখানে 40 থাকে, কে কম? 40। তাহলে আমার এই অক্সিজেনটা কি হবে, এখানে আসবে না এখান থেকে অক্সিজেন যাবে? এইখান থেকে বেটা অক্সিজেন এখানে ঢালবে। খুব ভালো কথা। এখানে আছে 46 আর এখানে আছে 40, তাহলে কোথায় যাবে? কার্বন ডাইঅক্সাইডটা, কার্বন ডাইঅক্সাইডটা এখানে ঢুকে যাবে, অ্যান্ড দ্যাট ইজ এক্সেলড। তাহলে কি দাঁড়ালো? Any gaseous diffusion, any gaseous exchange depends upon the thickness of the respiratory membrane, number one. The thickness is important, I am coming. Thickness of this is important, and pressure gradient is important between the two areas like alveoli and pulmonary tongue, or you can say pulmonary artery, or you can say pulmonary circulation, you can say pulmonary capillaries, anything you can say. আমাকে এখান থেকে সিম্পল ডিফিউশন এটা হবে, সিম্পল ডিফিউশন। সো নাও ইয়োর কনসেপ্ট ইজ জেনারেল ফিজিওলজি। সম ফর দ্য কনসেপ্ট অফ জেনারেল ফিজিওলজি, সিম্পল ডিফিউশন নিডস সাম মেমব্রেন, অ্যান্ড ফর দ্য প্রপার ডিফিউশন দ্য থিকনেস, যত থিকনেস কম হবে তত ভালো ডিফিউশন হবে। নাও এক্সাম্পল, সাপোজ এই পেশেন্টার ফেলিওর হয়েছে, রাইট ভেন্ট্রিকুলার ফেলিওর, রাইট ভেন্ট্রিকুলার ফেলিওর হচ্ছে, ভালো করে পাম্প করতে পারছে না, কনজেস্টিভ কার্ডিয়াক ফেলিওর। তাহলে ব্লাডটা কি হবে, এখানে কি হবে, কি হবে, এখানে বেশি করে ব্লাড যাবে, কম যাবে না। ফেলিওর মানে এমন না যে টানতে পারছে না, ব্লাডটা এখানে জমে থাকতে থাকবে, পাম্প করতে পারছে না। এখানে কি হবে না, কনজেশন হবে। যেখানে কনজেশন হলো, বেশি ব্লাড হলো, পারমিয়াবিলিটি বাড়বে। পারমিয়াবিলিটি অফ হোয়াট? সলভেন্ট, ওয়াটার। তাহলে ওয়াটার লিকেজ হবে, কোথায় যাবে? অ্যালভিওলাই। দ্যাট ইজ কল্ড পালমোনারি ইডিমা। দ্যাটস ওয়াই any left ventricular heart failure ultimately causes the pulmonary edema. The pulmonary edema means what? Fluid in the alveolus. কিভাবে এলো? Water leakage. কেন এলো? Due to the increased permeability. সো এখানে যদি লিকেজ হয়ে গেল, তাহলে আমার এখানে একটা ওয়াটারের লেয়ার পড়বে, লেয়ার। এগেন দিস থিকনেস অফ দ্য রেসপিরেটরি মেমব্রেন ডিক্রিজ না ইনক্রিজ? ইনক্রিজ। তাহলে আমার সিম্পল যে ডিফিউশন হচ্ছিল কম হবে না বেশি হবে? কম হবে। তাহলে আমার যে অক্সিজেন প্রেশার গ্রেডিয়েন্টে আসছিল সেটা আসবে কম। পেশেন্টে যদি পার্সিয়াল প্রেশার অক্সিজেন কম আসে, তার এখানে যে 108 থেকে এখানে 40 আছে তাকে কম্পেনসেট করার জন্য যে আসছিল, এবং এখানে যে এখানে যে আমার এটা হচ্ছে পালমোনারি ভেন, দ্যাট মিনস অক্সিজেনেটেড। এখানে এখানে হচ্ছে আর্টারিয়াল, এখানে PO2 অ্যাট দ্য ভেনাস লেভেল, দ্যাট ইজ পালমোনারি ভেন। এখানে কত হয়ে যাবে না 100। এটা যদি দেবে বলেই তো হবে। তাহলে ইফ দেয়ার ইজ এনি প্রবলেম অফ দিস ডিফিউশন cannot be reached at this level, and so the patient may present as a respiratory problem, যেটা তোর কাছে আসবে, শ্বাসকষ্ট হচ্ছে স্যার, তারপর তুই দেখলি যে হার্ট রেট অনেক বেশি, তার হিস্ট্রি আছে, আগে 1-2 বার ফেলিওর হয়েছে, বা হিস্ট্রি নেই, চেস্টে দেখলি এসপিটিসি হচ্ছে, চেস্টে তো দেখবি করতে করতে দেখলি যে বেজাল রিজনে ক্রেপিটেশনসের হচ্ছে। ক্রেপিটেশনস মানে কি না শুনলে তোরা বুঝতে পারবি না, বাবুলের মধ্যে সাউন্ড, বাবুল। That crepitation sounds is due to the fluid in the alveolar space, that is the pulmonary edema. So any patients come with respiratory distress having the basal crepitations, always suspect the patient having some heart failure patients, left ventricular failure, right ventricular patients may occur. If patients having the left ventricular failure continuously, then ultimately it come into the right ventricular failure and congestive cardiac failure, and that's why hepatojugular reflux আছে না এগুলো জিআই সিস্টেমে। সো দিস আর অল রিলেটেড। সো দিস partial pressure as well as thickness, and now the fourth one is a surface area. Surface area তাহলে কি কি ফ্যাক্টর আমার এখানে লাগলো for the important for the gaseous exchange? Number one is a respiratory membrane thickness, proper thickness of respiratory membrane. Partial pressure gradient is important from the high pressure to the low pressure. The gaseous exchange is happening. Number three is a yes কি বল surface area. Number three is a surface area, and also the importance of that the branching of the alveoli. এখান থেকে যদি কোনো ব্রাঞ্চ বেরিয়ে গেছে that is also described. Any patient having some hypoxia, all the system will কি করবে vasodilatation করবে না vasoconstrict করবে vasodilatation করবে, but in case of lung vasoconstriction. Why? Because যদি আমার এই অ্যালভিওলা এটা খারাপ থাকে আর এটা ভালো থাকে, এখানকার ভেসেলসের এক্সচেঞ্জটা কমিয়ে দেবে by doing the vasoconstriction, and এখানে সে ব্লাডটাকে ট্রান্সফার করে দেবে যাতে এখানে ভালো করে এক্সচেঞ্জ হয়ে আমার পার্সিয়াল প্রেশার অফ O2 মেনটেইনড হয়। To maintain our partial pressure of oxygen is our main target, as well as to keep at the constant level of partial pressure of O2. কেন partial pressure is CO2 কেন কার্বন ডাইঅক্সাইড বেড়ে গেলে মুশকিল হবে, কেন হবে অ্যাসিডোসিস, বেরিয়ে গেলেও মুশকিল হবে অ্যালকালোসিস। So metabolic alkalosis, metabolic acidosis, all the concepts are coming from this level. তাহলে এখন পর্যন্ত কি জানা গেল যে অ্যাটমসফেরিক প্রেশার যেটা, that is collectively all the gases atmospheric pressure, partial pressures, that may be nitrogen. Now you can questions me that how sir yes, these important questions. Then why nitrogen is not happening here? There is no questions of nitrogen. That means some fourth factor or fifth factor for the gaseous exchange is the solubility. That is the solubility of what? Solubility in the blood. Nitrogen is not at all solubility. So there is no question of any chances of this gradient change. So solubility also dependent factor of this proper gaseous exchange. That's why nitrogen হইবে না, নাইট্রোজেনের সঙ্গে আমার কোনো solubility ম্যাচ করছে না। নাইট্রোজেন আমার এখান থেকে এখানে থাকলেও এখানে কখনোই আসবে না। প্রেশার মেনটেন করতে পারে, প্রেশারটা কি হয় নাইট্রোজেন, আই এম নট গোয়িং ডিটেলস, নাইট্রোজেন ইজ এ বোরিং বেসিক্যালি, ইটস নট মাই কনসার্ন, বাট নাইট্রোজেন ইজ হেল্পফুল ফর ডিফারেন্ট টেস্টেস. If time permits, you explain in the next different classes. This nitrogen pressure is 595, not so exactly, I am not remembering, 59 something is there, but this will change into here into the 569, 67. That means pressure drop is happening here. That means what? Partial pressure of nitrogen is happening due to the conductive system, just like our oxygen. Well, here is 159 millimeter Hg and here is 104 millimeter Hg. Anyway, if it is 104 and it is 40, oxygen will always come into the blood vessels or pulmonary capillaries for the diffusion. Simple our diffusion is essential. If thickness is important, because if thickness is increased, এই জায়গাটা বেড়ে যাচ্ছে, then the diffusion time will be much more. কিভাবে গ্রাফ করা যেতে পারে, কিভাবে you can graph that. This is 0.1, 0.2, 0.3, and PO2. It's a PO2, and this is suppose okay, and it's a 50, it is our 25, right? Like that is a 40, we can start like that. So what is happening here? What is happening here? Saturation is going on and the partial pressure achievement is going on if the thickness is correct. If thickness is much more, then the graph will be like that. So never reach that place because is high, never ever can reach to the partial pressure of oxygen 100, that is a normal, that cannot be reached due to the thickness. Thickness किसे किसे बढ़ते बारे একটা বললাম pulmonary edema, আরেকটা কি বললাম, একটা heart failure, আরেকটা হচ্ছে pneumonia. How pneumonia can change your thickness of the respiratory membrane? Any idea about that? হ্যাঁ গেল, ব্যাকটেরিয়া গেল, দেন so concept must be clear. Bacterial infections accepted, viral infections, fungus dio pneumonia hote pare to, fungal may cause, viral may cause viral pneumonia, bacterial pneumonia can happen, any type of pneumonia. Can agents, offending agents are there, if offending agents are there, there is a pro-inflammatory cytokines to release. If cytokines are released, then the vasodilatation will happen where pulmonary circulations, and if so, then against that funda will come, there is a leakage of the fluid and then causing the pulmonary edema and increase the thickness. Simple. So thickness is increasing, then the pathogens and the respiratory distress. Respiratory distress means our PO2 at the blood level have been reduced. If I go for the ABG, the arterial blood gas analysis, this is important for ICU, then you can see the PO2 level, suppose it is 75, 85 around. So that means there is a grave concern about that. This area is not profusely, it's not properly exchanging proper level due to these thickness changes. If it is thin also, that can exchange much more. If much more exchange is happening, then what will happen? Suppose তখন ধরে বলছিলাম যে thickness বাড়াবার কথা, এবার কমিয়ে দিলাম, কমে গেল, thickness আমার কমে গেল, কিভাবে হবে কমবে? thickness কমে গেলে আমার অ্যালভিওলার যে এপিথেলিয়াম আছে তার যদি কোনো ড্যামেজ হয়, যেমন এমফাইসিমাতে আমার থিন হয়ে যাবে, আরো থিন, and that's why this layer, কথা বলবি না, and this layer, cell layer will be thin, and so thin level, that means diffusion will be much more easier. The diffusion does not mean that the oxygen will only come, it also diffuse the more carbon dioxide, so carbon dioxide wash out will be much more. If so, then the patient may come with a metabolic alkalosis. That is also must be clarified about that. This is not the acceptable range, but body can always are there. If carbon dioxide is remained in the blood, then our I/E ratio, আমি একবার বলেছিলাম, in the ventilator setup, I/E ratio, inspiration and I/E ratio আমরা বাড়িয়ে দিই কেন? To wash out the carbon dioxide, because if carbon dioxide retention is much more, then there is a problem of metabolic acidosis. কেন? Now carbon dioxide reacts with water, right? And it's carbonic acid and H plus ion is a pH level will decrease. Carbon dioxide increase each 10 millimeter of Hg, reduction of the pH of 0.1. If 7.4 is pH and carbon dioxide is suppose 70 millimeter Hg, যেটা আমার 40 থাকার কথা, then the 30 বাড়লো, তাহলে 3, তাহলে আমার 7.1 হয়ে যাবে। 7.1 is the dangerous pH level for the metabolic acidosis. So we have what to do? Ventilator setup, PEEPs must be increased and I/E ratio will be increased. It's a different aspect of your class. It's not your domain now. So anyway, this is a basic pathology. Always you think about the why is the pathology, pneumonia, pulmonary edema, thickness কি হচ্ছে, gaseous exchange, surface area. Now last is the surface area. What do you mean by surface area? এই যে একটা গুলো is a singular and alveoli is a plural. So these things happening, what is happening here? These are the tissues. These are the tissues are there. If any, by chance, elastase activity much more higher, or antitrypsin deficiency is there, or chronic smoking in a smoker, patient is having, so this elastase will be lost. তাহলে সারফেস এরিয়া বাড়বে না কমবে? সারফেস এরিয়া কমে যাবে। কারণ আমার যখন এইগুলো ছিল তখন আমার এখানে ব্লাড ভেসেলস গেছে, ব্লাড তাকিয়ে, so here this is the blood vessels are going on, and this is also this like that, so much, এইগুলো কিছু নেই, কিছু নেই। আর fusion or exchange বাড়বে না কমবে? কমে যাবে। The surface area is surface area, if it is increased, then the diffusion there, that is the emphysema. And I already explained emphysema means পুরনো মজা, তাই তো বলেছিলাম না? পুরনো মজা মানে কি? যাবে ভালো করে কিন্তু কি হবে? আসতে পারবে না। any kind of obstructive means কি problem in out, any restrictive disease is problem in problem, that is the pulmonary fibrosis, like your socks in the washing machine. So what is happening? It's always relations is very important. So elastic, from where elastase is coming? Neutrophil. So when the nicotine engrossment or nicotine inhalations is there, then the neutrophil will be stimulated and so release the elastase enzyme. So the elastin fibers of the alveoli will be damaged. So the divisions and the surface area will be reduced, and হবে কেন হবে না? কিন্তু এর মতো কি হবে? হবে না। তাহলে factors are important. In your exam, I am seeing last for 3 to 4 years basically, different numbers of factors are coming. Write down the factors of this, that. So these factors are very important to understand the proper basic pathology and pathophysiology. That's a term is called the pathophysiology. So number one is the physiology, then the pathology. So for today's end of this my class, the take home message is that our gaseous exchange is important for respiratory system much more, and that's why partial pressure gradient is important. Thickness of the respiratory membrane is important. Respiratory membrane means alveolar cell type 1, type 2, basement membrane or basal lamina, and endothelium cell of the pulmonary circulation or pulmonary capillaries. And the surface area is important. Solubility of the gas is important. Already explained about the nitrogen. So nitrogen, oxygen, carbon dioxide. If you forget everything, at least you can remember these two things, that oxygen in the atmosphere level is partial pressure is 159 millimeter of Hg, and carbon dioxide 0.3 millimeter of Hg, and inside the alveolus partial pressure of O2 is 104 and partial pressure of carbon dioxide is 40. So the pressure gradient between these and these one happening, so the gaseous distance is coming on. So these things are diffusions happening due to this area is ultimately goal our respiratory system. Whatever you can say, the static compliance, dynamic compliance, ultimate aim is to maintain our PaCO2 and PA means arterial blood gas analysis. After that, the PCO2 and PO2 must be in the maintained level, so that to avoid the alkalosis and acidosis as well as oxygenation. That is called oxygenation. If this is happening, it is coming into this way, this is called oxygenation, not the ventilation. Ventilation means in, exchange and out. This is the ventilation. Concept is that. Clear? Any doubts about this class? Thank you very much. So dismiss my class. Thank you.
As the lymphocytes go to the thymus to be processed, and where they come out as T lymphocytes. And T lymphocytes are important because they kill the viral infected cells or abnormal cells by themselves. And these T lymphocytes are important for cell-mediated immunity, in contrast to B cell, which is solely responsible for humoral immunity but both act at times together. In the peripheral blood, 80% of the T lymphocytes are there and B cells are 15%. Now, the B cells, the name originates from the birds of Fabricius, which are present in the birds. You see, many of the invention discoveries originated originally from non-human sources. Now, we are having an equivalent amount of lymphoid tissue, that is Pierre's patch, and the lymphoid tissue within the chest lung associated lymphoid organs, where they mature to become B cells. So, these B cells in course of time, when encountered an antigen, as I will show you slightly later, that they get converted into plasma cells, and these plasma cells produce the immunoglobulin, not the B cells by themselves. Without conversion into plasma cells, antibody will not be produced. See, this is what I told, that in the bone marrow, that pluripotent hemopoietic stem cells are there from where the cells get differentiated, and one is in the myeloid series and another is lymphoid series. In the myeloid series, we get the cells which are neutrophil, eosinophil, basophil, mast cell, and the immature dendritic cells. Dendritic cells, they constitute the innate immunity, where prior exposure is not required. They themselves are programmed. They are having PRR, that is pattern recognition receptors within themselves, and they, the moment they encounter a microorganism or microbe which are having PAMP, that is pathogen associated molecular pattern, they recognize and then they kill it. Also, the natural killer cell belong to the innate system. Adaptive immune response is responsible, as I told you, it is because of T cell and B cell. T cell converts cell penetrant and B cell converts humoral immunity. Now, these immature dendritic cell, they become mature dendritic cell and then they become functional only. So, these basic functions of these cells you must remember. Some are unique. As a rule, you remember that all the cells almost produce cytokine, and the important function of macrophage is phagocytosis, because they engulf the bacteria or virus and then they kill. That is basic job of macrophage. Mast cells, remember, the histamine is released from the mast cell and eosinophil, and these cells are involved in the allergic manifestation. See, dendritic cells, basically they are also killing the cells that they are told as they are described as the antigen presenting cells. Any cell can present antigen also, macrophage also present antigen, but we in association with a different class of MHC molecule, that is major histocompatible complex molecules, which I will tell you later. And the neutrophils, as you know from your class 9, that it kills bacteria, basically it phagocytosis. So, eosinophil is basically related to histamine release, and its number is increased in allergic condition. And basophil, again parasitic infection. So, in the T cell and B cell, there are highly specific receptors. Look at the structure of the receptor. The structure is quite different than the B cell. The B cell produces antibody on conversion to plasma cells, and some of the cells become memory cells, as I will show you later. And these cells which produce the antibody will express the same antibody which gets attached onto its surface. In contrast, T cell is having a different receptor, but in association there is another molecule which identifies MHC molecules, as you will see. So, these T cells can kill the cell directly, but B cell do not have that capacity. It produces antibody. So, these receptors, these are called TCR, that is T cell receptor, and B cell is called B cell receptor, and these are very important in recognition self from the non-self, because until and unless something is foreign, body will not mount any response, immune response. If it fails to identify between the self and non-self, obviously immunity will be mounted against body's own tissue and autoimmune disease will occur. Remember, one B cell is endowed with the capacity of forming only one type of antibody, and the number of receptors in a B cell is of the order of 10 to the power 5. So, that many numbers of receptors are there in the B cell. The moment we encounter any foreign antigen, the B cell recognizes that particular antigen, and that cell undergoes proliferation. That is selection of that cell, that is called clonal selection. Clone means one cells originating from a group of cells originating from one cell. So, that clone of cells will be produced and that will go on expanding. So, a part of that cells will be formed. See, you see, look at this thing. These B cells are recognizing antigens. You can see the receptor, different types of receptors are there. Now, this is recognizing antigen, and then this cell is undergoing mitotic division, and this cell is again mitotic division, this cell again mitotic division. Similarly, on this side. But look at this thing, that some of the cells are secreting the immunoglobulin, some are not. Those cells which are secreting immunoglobulin, they produce antibody, and rest of the cells, these are cells which are not producing, they are remaining in the body as memory cells, and they remain stored the moment we get an infection at a later date. Because of the huge number of these cells, they produce antibody instantaneously in a very large amount and with a very high affinity and very rapidly. So, this is what is called clonal selection. It means a particular cell will be selected from which a clone of cells will be produced, and this will undergo expansion, and there will be creation of memory cells from this pool. So, I am giving you another example. See, there are three types of receptors, but out of which only that cell will, which is having the particular type of receptor, will combine with this thing, and that will undergo clonal expansion, and part of the cell will be forming the antibody, and the rest will be remaining as a memory cell. Same thing is true for T cells. The T cell is recognized in this one. Again, T cell will be classified into three different types: T helper, T lymphocyte. I will tell you very briefly. So, the moment we get a first infection, that is called primary response. In the primary response, the antibody response is very low, because we don't have that much amount of B producing cells. In this phase, this primary response, the B cells are produced, some B cells are produced to which form antibody, rest of the cells remain as memory cells. The moment we get a second exposure, the response is very fast and it is larger, and the affinity of that particular antibody also changes. And there is another important thing is that there is class switching, that not only larger response, not only affinity increasing, but also class switching without changing specificity. That IgM type of response in the primary response, this is found. In contrast, IgG type of response antibody will be formed in the secondary response. This will indicate a recent infection or an older infection. And during vaccination, the same thing occurs, because we are introducing an antigen, and that will mount a similar counter response. So, this is the difference. This you must remember at this stage. What is the difference, basic difference between the two things? That innate immunity is present from the birth. It is inherited germline. So, we cannot really change it. This at the time of birth, like say everybody is coming out prepared for out of house, something, taking something, say same thing is true for us. That when we are born, we are endowed with that some genetic power, and that comes from germline gene. In contrast, adaptive immune response requires an exposure, and it occurs due to somatic recombination of genes, as you will see later. So this is a first line defense. The physical barrier, after the physical barrier is crossed somehow, that innate system will be the first line system, but that is a less potent system. This adaptive immunity is a second line, but it is a more potent system. A specificity, there is no specificity in this thing. Microbe, virus, bacteria, parasite, whatever it enters, it will try to engulf. So it is non-specific. In contrast, it is specific. Something will be, you just try to remember, this will be, this is being recorded, you can take time. Only thing is that you will listen properly and simply read the book. Nothing I am telling very specific. Only thing is try to understand at this stage and try to memorize as much as you can, because you will not read, you will not be able to get time. You will not be see, this response is immediate and short, this primary response, this innate immunity, but it is slow and delayed. Maybe you know that measles vaccine, you have taken only one dose and you have achieved a lifelong immunity. So immunity can be lifelong also on exposure of some antigens. So interaction here occurs PRR, that is present in the host, that is pattern recognition receptor, I repeat, and PAMP is pathogen associated molecular pattern, that is uniquely conserved. Both are uniquely conserved. We are having many microbes, but that particular genetic component which shows a particular type of sensor, that is what you can say, this PRR basically sensor of the human body, and in the bacteria also they are also having a similar kind of structure, the interaction between PRR and PAMP. And here the interaction occurs between a microbe which is presenting as an antigen or a non-microbe. We can develop allergy also, because allergy is not a microbe. Similarly, many of you, I think all of you have taken tetanus toxoid. Toxoid is also not microbial, but it is a non-microbial entity, but against which we mount a response, and there is a reaction between antigen or a hapten and antibody. So memory here, there is no memory, because it is present from the birth, it does not require any exposure. But here memory is present, the cells involved, that is what was asked in the question. These many cells are involved in the innate immunity. That you must remember, that is natural killer cell, natural killer lymphocyte, monocyte, macrophage, you must tell all these things, dendritic cells, these, at least these 4 cells you tell. The rest of the things you know, that neutrophils, basophil, eosinophil, tissue mast cell and epithelial cell. In contrast, here it is B lymphocyte and T lymphocyte. There are other components of innate immune system. So to summarize, the immunity can be adaptive, it can be innate. Adaptive immunity can be occurred, we can get it naturally. How we naturally get? From the mother. Passively, the immunoglobulin IgG is transferred to the fetus, and we get a passive immunization. In contrast, we acquire an infection, and then we mount a response, primary response, secondary response, and that is called active. Similarly, artificial, passive. See, today, right now, you are having a patient who is likely to have a tetanus or a gas gangrene. Immediately, you give anti-tetanus immunoglobulin, not toxoid. That anti-tetanus immunoglobulin will act rapidly, immediately. Similarly, if there is a snake bite, we cannot wait for time. Immediately, we have to give the antibody so that it will neutralize the toxin present in the snake venom. So that is basically passive. So antibody we are transferring either as immunoglobulin or in the form of serum, particularly for anti-venom serum, where it is, and the active. Active means immunization. All of you have been immunized. During our time, only we had the smallpox vaccination. During our time, this classical OPV vaccine, tetanus toxoid, MMR, these were not existing, and accordingly, people of my age were not vaccinated. In contrast, you are, because a large number of diseases, infectious diseases, have been prevented by this active immunization process. So this is an important thing which is likely to be asked in the examination. Describe the structure of immunoglobulin and discuss its functions. One good question. So you must remember that the immunoglobulin is composed of 2 heavy chains and 2 light chains. This heavy chain is having this part and the light chain is the other part half. In the light chain part, there is in the variable region which is constituting the antigen binding site, that is FAB portion. And remember, there is only a single type of light chain, whether it is kappa or whether it is lambda, it will be present, it will not be a mixture of the two, as I told you earlier. And the variable region of IgG, for example, the first 108 amino acids of the light chain and 118 amino acids of gamma chain will constitute the variable part, which will bind to the antibody, and that is specific. So this function of IgG is very important. So immobilization, because it is binding, so it will cause agglutination. The agglutination is, what is agglutination? Agglutination is basically formation of antigen antibody complex, throwing it out of the solution so that you can get a visible precipitate. Opsonization means the bacteria surfaces are negatively charged, macrophage surfaces are negatively charged, so they will try to repel each other. So the moment if something is covered on the bacterial surface, that will prevent that charge on that microbe. So opsonin does this thing. IgG or antibody is one type of opsonin. Complement is another. There are 50 other different types of opsonins which are present. So that once you opsonize it, then it will be easier for the macrophage to phagocytose. The activation of classical pathogen complement system, because this is a separate thing altogether, and neutralization of toxin. This is one important. Bacteria produces toxin. So once the body is invaded by bacteria, the bacteria will start proliferating because the environment they get is very much conducive for their growth. So they will produce toxin, and since IgG having 2 antigen binding sites, they will immediately neutralize this antigen. And antibody dependent cell mediated cytotoxicity, I will tell you a little later. And this IgG associated with type 1 to type 3 hypersensitivity reaction. What is this? This I will. There is no scope for discussing all these things, but maybe in the small group discussion I will say. So this I told you earlier. Again I am repeating that IgG is a monomeric structure. IgG usually can exist as a dimer, or it can be as a monomer. In contrast, IgM is always pentamer, and it is joined by a J chain. Here it is, there is a J chain, and you see this IgM can bind 10 antigens together. So IgM is a very good agglutinating antibody, because this IgM is remaining somehow in the solution because of some of the groups. The moment the binding sites are occupied, that they will lose solubility and it will be thrown out of solution. And detection of blood group, perhaps you have seen that a drop of antiserum is added and you can see the visible curdling, and that is a classical example of agglutination. Because of the pentameric structure, immediately will say visible clot within say 30 seconds time. So this part, the upper part, you can see this is the antigen binding part, and this FC part, this is the biological activation. This is a catch question for the viva. What is papain site and what is pepsin site and what is the complement binding site? Remember, FC portion is the complement binding site, and the papain site is a little bit ahead of this hinge region, and the pepsin is a little away. These two chains are joined together by disulfide bond, and these two chains are together by two disulfide bond. See, this is asked. If we digest immunoglobulin, what we will get? What we will get? See, if we digest it papain, you can see the papa. There are two PAPA. That means you will get two fragments of FAB. It will cut here. So you will get two fragments of FAB fragment. In contrast, if you cut it with pepsin, pepsin will cut a little away. So you will get one FC fraction and one FAB fraction, but that FAB fraction will contain two antibody binding sites. Now, why it is important? The basic purpose is that we have to study the functions of the immunoglobulin. The way I am representing here, in reality it doesn't occur. It's a totally schematic representation. Now, how can we study that different parts, whether it is antigen binding, whether it is complement binding, that we cannot study really. So, that if we fragment it, now we will get these two fractions. And now if we incubate with antigen, then it will bind, but this complement will not be bound. The complement will be bound to this FC fraction. Now, when we design an assay, this is occupying some amount of space. So, we can take this fragment and we can design an immunoassay, because we want basically the binding sites, not the FC portion. FC portion is required for phagocytosis, for complement activation. So, this classification, again I am telling you repeatedly, there are 5 different types of antibody you must remember, and the highest concentration is present in the serum is IgG. IgE is present in the least concentration, and it is related to allergy. The moment somebody is suffering from some allergy, or if the IgE level is found to be very high in any individual, be sure that the patient is having allergy for something until proved otherwise. Usually, if the patient is suffering from complaining of some kind of infection, a prescription is given, make an IgG estimation, and the level is usually high. So, these subclasses of IgG, there are 4 subclasses, and IgA, A is basically IgA1 and IgA2. These are 2 subclasses. So, IgA is present basically mostly in the secretions, body secretions, be it tear, be it nasal secretion, be it just GI secretion, be it genitourinary secretion. These secretions in the surface, they give immunity. The moment a pathogen enters, it binds to that particular pathogen and doesn't allow it to enter into our system. So, out of these 5, I have deliberately chosen these 3. So, these 3 are important. IgE is classically responsible for allergic reaction. See, primary response IgM, I have been repeatedly telling the primary antibody is IgM. IgG is for secondary response, and in external secretions IgA is the most predominant antibody. Placental transfer is possible with IgG type of antibody until and unless the fetus gets infected, fetus will not produce IgM antibody. Agglutination, as you have seen that there are it is a pentavalent, that means one IgM can bind 10 antigen or hapten together. So, it will be no longer remaining able to in the solution, it will be thrown out of solution. It is a very good agglutinating agent in contrast to IgA or IgG, and complement fixation is maximum here with the IgM type and less so with the IgG type. So, there are 3 different types of antibody, one is isotype, one is allotype, one is idiotype. This is again a catch question or small question in the Viva, what is the difference between the 2? Remember, isotype determines the different types what I have seen, alpha, beta, gamma, mu, delta, and the subclasses, that is isotype. What is allotype? we are having allelic variations. We all are human beings, but all of our faces are not same, even though from the same sibling, from the parent to sibling. We don't have the similarity. We are having some amount of differences. This is called polymorphism, and that does occur with antibody also. So it's a variation here. It is only in the H chain, in the constant region. Remember, this is variation in the H and L chain, but in the constant region. In contrast, in idiotype, it is variation in the variable region, and both in the H chain and light chain. Here I am showing you here. You see the variation here. All the chains are different, heavy chains. But you can see there is also difference here, and that is what is allotypic determinants. See allotype. You see that this structure is not present here. This structure is present here. So this is allotypically same, but there is a difference. Here it is same, almost. It is not also same. You can see look at the structure. It is not same. It is not same, and this is absent here. So that is allotype. So slight variations will be there. And idiotype is basically determining the absolute difference at the antigen binding site. So this part again I am repeated. I told you earlier. Again I am telling you this. You must remember the different functions of different immunoglobulins. Remember whatever I have written in the red. You must remember at least, and it should be at least these are most important part. That is IgG is an antibody of the secondary response. Is that only antibody which crosses the placenta, presents maximal amount in the human serum, and it indicates cold exposure. IgA is present in the surface, in the body secretions, and that confers surface immunity. IgD is not that important. IgE, I told you earlier, again I am telling you, it is responsible for immediate type of allergic reaction, and IgM is an antibody of primary response. It's a high agglutinating and complement fixing capacity, as I have told you, and it can be produced by fetus, as I told you, if the fetus gets an infection. This was supposed to be finished in the first class, but again, why so many antigen, different types of antibody we produce, a human body was produced? We are having 158 genes, but we produce an innumerable antibody because we encounter innumerable antigens, and this is because of the VDJ of H chain and VJ joining of the L chain. That confers a ঘড়িটা কোথায় ঘড়িটা কোথায় আছে আমি তো and L chain. So this you will get in your Vasudevan's book. They have written basically. See, the V region they are having 500 genes, J region they are having 6 genes, and constant region there is a C, 20 numbers. So any combination can occur. One can take here, one can take here, one can take here, and they produce an antibody which will be of this structure, and this antibody will be finally produced. The only problem here is that, as you will see the next time, that this occurs due to somatic recombination. See, I tried to see whether the number is there uniquely present in other references also. I spent the whole Sunday on searching it out, whether the DM Vasudevan book, which was showing the same number in 2013 edition and 2023 edition. That means 10 years there is no change, and that was the point of suspicion, and I searched it. The Nature Communication latest edition, they said July 23. I got that it is 127, 9, 27 and 9, and this immunology book is there also. There, the number is also varying. I went a little ahead in searching other references. You see, the Vasudevan books gives information about the light chain, but there is no information of heavy chain. In Harper book, in the latest edition book, that is 2023, there is no information about what is the number. Harrison medicines, which you will see read in the medicine book, only information is about kappa and lambda, but no information on heavy chain, how many genes are there, and the number is quite different than what is written in the Pasadon books. How this is 2013 edition can write 500 VL gene, in contrast, Harrison latest edition 300 genes. Then nature communication, as I told you earlier, and Royd's Immunology is another book, good book on immunology reference book. The number is here. And again, I searched what was the reference of the older edition, that 2008 showed that B was 50. So that means over a period of time, a good number of genes were discovered. So that is another point of controversy. So somebody was asking about making a paper, research paper. So how much study is required? You can imagine that you have to identify what are the differences and why it is lacking and why it is so. Then only you can make a research work and make a paper. So he got the Nobel Prize because of that thing I told you earlier. Something new, major histocompatibility complex, that you remember only on a small part, not all of this thing, only three. Remember there are three classes are there, one class 1, class 2 and class 3. Class 1 is present in all cells, class 2 is present in B lymphocyte, macrophage and T lymphocyte. Remember this much, not more than that. The importance is that they are closed linked genes and they are inherited en bloc. And that is the reason why a sibling or a brother or sister is a better donor for bone marrow transplantation than the parent, because parent is having only half of it. But in contrast, the sibling, either the brother or sister, will be nearly having 100% matching. So you see the importance is that whenever somebody is suffering from some cancer in the bone marrow or a bone marrow transplantation is required, after bone marrow transplantation is required, it is very difficult to find a suitable donor. Father and mother can give, but they are having half HL haplotype matching. Brothers sisters are good, they can give almost identical, provided they match, but that is not true 100%. If you don't get anything, you get an unrelated donor and there will be no matching, and there is a high chance that it will be rejected. That is the importance of this matching. This is cell-mediated immunity. So cells which are directly involved for killing or destroying the infected cell or the cancer cell. So these are the three important functions you must remember. That activation of phagocytes, that is macrophage and natural killer cell, production of antigen-specific cytotoxic T lymphocyte, as I have shown you earlier, and release of various cytokines in response to antigen, that I have also shown. So T cells are basically, for you to remember, is T helper cell and cytotoxic T cell. Helper T cell helps in production of antibody. Cytotoxic T cells kills the cells, it is a viral infected cell or cancer cell directly. There is another type of cells, that is T cell, regulatory T cells. That regulates the activity, that does the job of policing action. So this is a central role of immune response. You see, this is a T cell, this is phagocyte, macrophage. Antigen has been engulfed within the system. Now this antigen will be processed and it will be presented in association with MHC class 2. The T helper cell is there. And this is another cell, B cell. It is not macrophage. The antigen is present on the surface and it is bound to antibody. And you can see there is a signal, but this signal is a different. This is receptor CD28 and this is CD40. This is a ligand, this is a receptor. So this is the way how the cell help T cell and the B cell and the B cell and the macrophage also to engulf the system, engulf the bacteria, or help in the antibody production. This function you note it down, this is not available in your book. What are the functions of T helper cell? These T helper cell are basically releasing cytokines. They are essential for B cell class switching, breaking cross tolerance in dendritic cells, activation and growth of cytotoxic T cells, maximize bactericidal activity of phagocytes as I showed you, and expression of the surface protein CD4. Note this thing near these points down, which is not available in your book. This is T cell dependent activation. The way we say it is not that easy. It is a schematic diagram, much more complex than what we can really understand or realize. It will take nearly a decade's time to understand the immunology for any medical students to some extent, not completely. So cellular immune response, you can see the cells are here. This virus has been infected and it is inside the cell. Virus is undergoing replication. Now this is fragmented and this is a processed antigen. The macrophage is processing the antigen, and that processed antigen is now presented in association with class 1 MHC molecule. Now these will produce the T cell, cytotoxic T cell in large number, and this cytotoxic T cell will be then killing in association with MHC class 2 molecule, and it will cause lysis of that particular cell. So immune system, when it fails to produce can kill directly, there are several other mechanisms by which an infected cell can be killed. So one thing you remember, since class 1 antigen is present in all the cells, so viral infection cell will present with MHC class 1 molecules. In contrast, professional antigen presenting cells are macrophages, dendritic cells, and they break that antigen that is usually protein in nature into small peptides, and then they present it onto the surface, and also B cell, and they express class 2 molecules. Remember, these are the two difference. Viral infected cell or cancer cell, they express class 1 molecule, but professional antigen presenting cells, which constitutes macrophages and dendritic cells, they present with MHC class 2 molecules. So cell mediated immunity, one important thing is that tuberculosis is a very common disease in our society. So somehow the disease has been controlled, but if you suspect a case to be suffering from tuberculosis, it indicates a cell mediated immunity, because the body cannot really kill bacteria, Mycobacterium tuberculosis. It resides within the macrophages, and they mount a cell mediated immune response, and therefore they try to control. But if there is a failure of the control, then the patient suffers from tuberculosis. And how then we will confirm? And that is a tuberculin test. You do a purified protein derivative of the tuberculosis is injected into the skin, and this response is seen after degree of induration. What is the degree of induration? And we measure, you can see this type of response also, and this induration is measured in terms of with a scale, and that will indicate whether the patient is having tuberculosis or not, and this is an indication of cell mediated immune response. That is an applied aspect. So antibody dependent cell mediated cytotoxicity, because it is antibody dependent, you see antibody will be there, and the natural killer cell will recognize this antibody Fc portion, and then they will kill. That is basically the antibody dependent cell mediated cytotoxicity. Self and non-self recognition is very important. As I told you, the innate system and the adaptive system having the capability to identify self and non-self. So selection by evolution, see our germline genes which we inherit from our parents is not a single day job. It evolved over crores of years of evolution, and this is present in all animals, vertebrates, right from smaller animals to vertebrate to higher animals like us. We inherit because we have to live in the hostile environment. In the environment is hostile for all organisms, not only for us. The moment we are born, so long we are in the mother's womb, we are somehow protected. The moment we are born in a hostile environment full of infectious agents. So we inherit that germline gene, and that germline gene by default tries to know what is self, what is non-self. In addition, so there is a capability of recognizing cells caused by infection, because then only it will be able to recognize. Adaptive system, it's constituted of somatic cells of T cells and B cells, and they express TCR and BCR as I have told you. And by virtue of the adaptive system, they are capable of eliminating any foreign pathogen. So enormous variety of these cells are there, and they are produced as a result of recombination. There is a high chance that there will be mutation. And by chance, if the mutation occurs and the body fails to recognize on its own, then it will mount an immune response on itself, and that is the basis of autoimmunity. So cancer cell also express new antigens, and that is the reason cancer cells are identified by the cytotoxic T cells, and that they are killed by the normal immune system. But if the number is very high, the immune system is overpowered, then cancer will definitely spread in our body. So there are two mechanisms, one is missing self, one is induced self. You can see here in the normal cell we are having MSC molecules, but the moment we get infected, there is a deletion of this MSC class 1 molecule, and the NK cells, that is natural killer cell, will kill this infected cell. There is another mechanism, this is an inhibitory receptor, it does not allow this normal cell to be bound. But when this is present, when infected cell expresses something like that, it binds with that antigen and then it kills. So missing self hypothesis is there, and induced self hypothesis is there to differentiate between self and non-self. As I told you earlier, there is a failure of recognition of self. If by chance our immune system fails to recognize our own body tissue cells in any way, in any form, autoimmunity is going to occur, and it can occur in any organ. It can occur in any organ. It can occur in multiple organs of the body also. That will cause a systemic immune disease. So production of biomolecules against self. The immune system, which is protective for us, is now attacking us, ourselves. So therefore, that is autoimmunity. Its cause is not simple, it is multifactorial, genetic, environmental, and immunological. As I told you earlier, that we are having a very strong association between psychology and immunology. This is not well documented, but many a times we do not suffer from cold because of our mental makeup. But the moment if we think that we are going to suffer from some infection, we will suffer from infection, whether exposure to cold or not. So any organ can be affected. The common organ which you will see in your clinical practice is thyroid, hypothyroidism or hyperthyroidism. Another is connective tissue disorder, rheumatoid arthritis, SLE, skin, psoriasis you will get, blood vessel vasculitis. The common autoimmune disease, you see Hashimoto's thyroiditis is very common. Every day in the OPD at least you will get 2 or 3 cases. So the moment you suspect Hashimoto's thyroiditis, you will advise for anti-TP antibody, and this is commonly done. If it is present, that means the person is mounting antibody against thyroid tissue, or TRAB or TGAB. Similarly, type 1 diabetes mellitus, which is relatively less common, seen only in 5% of the population, the B cell antibodies are present. Rheumatoid arthritis is very complex, associated with MSC molecules. As I told you, I did not get enough time. They actually DR4, and it is associated with DR4 maximally. Systemic lupus erythematosus, another very bad disease. involving the entire system, high chance of very crippled life. Nobody, death doesn't occur so easily, but they are kept under control with immunomodulatory drugs. There is no cure for that because anti-nuclear antibody is produced, anti-DNase DNA antibody is produced, anti-complement antibody, anti-phospholipid, anti-erythrocytes, what not. So all the body tissue systems are infected, getting affected. Psoriasis, it is also not known, but it is a common disease. Association is perhaps with MSC and class T cells. Now, last part is, I will try to finish it within 5 minutes time. Concepts involving vaccine. We all have taken vaccine. Now, what is a vaccine? You must remember the definition. What is a vaccine? A vaccine is basically an immunobiological agent which is designed to produce protection against a given disease by producing protective antibody or other immune mechanisms. It can confer both humoral as well as cell-mediated, depending on the type of vaccine you are giving. The vaccine which we produce, it must have immunogenicity, means it will be able to produce immunity in some form, either through production of antibody or through T cell mediated immunity or together. But it doesn't have a pathogenicity. If we take a bacteria and if we try to inject that bacteria, it is having two factors. One is virulence factor or pathogenic factor that will cause the disease. One is immunogenic factor. So, during vaccination process, that pathogenic part is destroyed or destroying the immunogenic part, so that immunity is mounted against that bacteria. And this is true for live attenuated vaccine. Means we will give the polio virus, is a live virus, which we ingest as a polio vaccine. But that is really a virus, but that virus is not having any pathogenic property, but is having immunogenic property. So that is the basis of this antibody vaccine. And there are different types. The most important type I am telling you, live attenuated vaccines. It is a live vaccine, means bacteria virus is there, is a live virus, but it has been, its power has been destroyed. So it is some kind of attenuation has been done. And how it has been done, I am telling you, or inactivated or killed vaccine. We have killed that bacteria and we are now using that antigen. And it can be a combination. And if you give a mass vaccination, that will cause herd immunity, HERD, herd means it will give a mass immunity also, so the community will be protected from that particular infectious agent and the disease will not be transmitted. So, live attenuated vaccine example are polio. Polio is we are having a kill type of vaccine also. The hepatitis B, again both vaccines are possible, hepatitis A, hepatitis B. Cholera, again intact, we are having a kill vaccine, we are having a toxin based vaccine. So, tetanus toxoid which we take is basically a toxoid based vaccine. Diphtheria, a toxoid based vaccine, and recombinant DNA. We use the recombinant DNA for hepatitis B, rabies, influenza, streptococcal, and of course of late that COVID vaccine. So, this is an expanded chart of that. You cannot read it, you will read it in the PSM book. So, this is a national immunization program. A number of vaccines are given to a child so that the child does not suffer from infectious disease in future. So, common vaccines which you all have taken is basically polio, diphtheria, DPT and MMR vaccine. Hepatitis B is required for healthcare professionals. I am telling you, I have not given hepatitis B to my wife, to my son and my sisters. I told them very categorically that you are least likely to be exposed to hepatitis, so don't take that vaccine. Since I am handling blood, I am handling patients, I am supposed to suffer from hepatitis B, I have taken the vaccine. So, one must be a little bit prudent in choosing which vaccine you will take. Deliberately I am telling you, I have not taken COVID vaccine, despite severe pressure on me, neither my son nor my sisters. Because I knew that there is no phase trial, clinical phase trial was given, and arbitrarily it was given, and COVID is a created disease. I will tell, and I am having adequate information on this. And because of the untried vaccine, I did not take any risk on vaccinating myself by causing some amount of harm. So while you are advising some vaccine to somebody else, you must be judicious enough. Take chickenpox vaccine, it is available. Must get an infection. It depends from person to person, perception to perception. I told you, let you be exposed with chicken vaccine, chicken virus. It is not going to kill you. You will develop mountain immune response. The same is true for influenza. How many vaccines you will take in your lifetime? There must be a limit for it. We are exposed day in, day out to a number of infections, but we are not getting infected. All the medical healthcare professionals are not suffering from infections. Only those infections which will cause a chronic morbidity or there is a high chance of mortality, definitely will consider for taking a vaccine. So, n number of vaccines, n number of companies will produce and they will try to promote it. So, you must be judicious, that is my point. You can differ from me, you can argue. I honor your decision, I honor your judgment, but be very careful. A number of vaccines are available in the market, and how many vaccines one should take. How much is too much, how less is too less. So, we are having an opportunity. So, how vaccines are produced? So, live attenuation is done by repeatedly passing in the cell culture, so that the virus loses its disease causing property, that is pathogenic property. Wild virus is basically that virus which causes the disease, a live vaccine. That is called a wild virus or pathogen. In contrast, live attenuated vaccine doesn't have that wild nature, but it retains the power of immunogenic power. Kill vaccines. So, they are grown in the culture and they are killed either by heat, that is called heat inactivated vaccine, or it can be caused by a chemical that is commonly used in formalin. So, it is safe in the sense there is no growth of bacteria, but here there is a chance of high growth of bacteria. Oral vaccine, polio vaccine, if you give, this virus will proliferate in the intestine and that will give a larger protection. Remember, the difference between the kill vaccine and the live vaccine is that live vaccine allows the virus to, or that conjugative agent to proliferate within the system, and it will give a good amount of antigenic load, and it will cause a much more immune response than the killed antibody, because there is no growth of bacteria. Of course, this is less efficacious, and most important part is these live vaccines can be given orally. In contrast, killed vaccines should be given parenterally. This means injection. Everybody is afraid of injection. A child is afraid of injection. If you give a drop, he will take it. If you show the needle, he will literally try to cry. So, choice is that. And toxoids. Toxoids are basically produced from toxins. Bacteria produces toxin, and in the bacteria are grown, and in the liquid medium they produce toxin, and that purification of the toxin is done, and from that toxoid that is inactivated with formaldehyde. So, when you design a vaccine, it must be safe. Vaccine cannot be unsafe. And with satisfactory phase 3 trial, this was not done in COVID vaccine, and that is the reason why I have not taken. Phase 3 trial means a large number of people have to be given, vaccinated, and the data must be available. So, then only it can be accepted, and all the immunization which we do has undergone phase 3 trial. And there are no minimum side effects, but desired immunity. Please remain quiet for 1 minute more, 1 or 2 minutes. This is the end slide, I think. So, live attenuated vaccines, please keep quiet, just 1 minute, I have to leave also. Live attenuated vaccines are more potent than kill vaccine, as I told you, because this will grow, proliferate. Oral vaccines are more preferable because there is no fear of injection, and no specialized persons are required also, where you require a trained person to give injection. And specific for tie or train, preferably single dose. Nobody wants a booster dose. 1 dose I have taken, that lifelong immunity, just like measles vaccine. Option of giving more than 1 live vaccine, 2 live vaccines are not given together. So, that option must be there. If you want to design a vaccine, try to look for this opportunity. As storage, another big issue, maintenance of cold chain. If the cold chain is not vaccine, if you give the vaccine, there is no effect of the vaccine. So if vaccine can be stored at room temperature, that will be preferred vaccine. At cost, of course, as low as possible. Immunocompromised patients are not given vaccine because they fail to mount immune response. Now, once you design a vaccine, you try to see that in the immunocompromised patient, it can be given also, so that they can also be vaccinated. So I dedicate this lecture to Edward Jenner, who invented the first vaccine, and it was first case of vaccination was done in 1796, almost 250 years back. Thank you very much. Go and read.